session brings together brilliant minds, innovative ideas, and cutting-edge insights. Our aim is to deepen understanding, spark discussion, and encourage meaningful collaboration. Now, I request Ms. Aishwarya to welcome the gathering for the session.
Good morning, everyone. It's my honor and privilege to welcome our keynote speaker, Dr. Shanmukhi, consultant clinical psychologist. I would like to welcome you, ma'am. I request Dr. Shanmukhi, ma'am, to go to the dais. We welcome you, ma'am. Now I request Ms. Ashwini H, ma'am, to welcome Dr. Shanmukhi with a bookmark. I would like to welcome Professor Vishwanath P, Principal, Dr. Soumya VP, Dean of PG Center, Dr. Vandana Jain, Head of the Department Psychology, and Ms. Ashwini H, Staff Coordinator for the session. Now, I would also like to welcome all our faculty members, non-teaching staffs, participants, and students who have gathered here. Welcome everyone to this technical session.
It is my distinct honor to introduce our guest today, Dr. S. Shanmukhi, a highly distinguished consultant clinical psychologist, neuropsychology, and epilepsy specialist with over 25 years of extensive clinical and academic experience in healthcare. Dr. Shanmukhi is a respected researcher and educator who specializes in neuropsychological interventions, psychiatric counseling, child psychology, and cognitive rehabilitation. She has co-authored over 25 peer-reviewed publications and mentored clinical research at MPhil and DM levels. Her distinguished career includes long-term roles as a senior consultant clinical psychologist at institutions like KIMS Hospital and in her private practice at UJIRE Health Center. She has also held key positions as a clinical psychologist in the Department of Neurology at institutions such as Nizam's Institute of Medical Sciences and Care Hospitals. In addition to her clinical work, Dr. Shanmukhi is a passionate advocate for ethical governance and mental health awareness. She has served as an external board member for academic committees, including Osmania University and the State Mental Health Authority, Telangana. She is a frequent speaker and panelist at national and international platforms, committed to elevating mental health services and education across India. We are honored to have her with us today. Please join me in welcoming Dr. Shanmukhi to deliver the technical session. Now, I would like to hand over the session to you.
Thank you chip, and that may cost you also. So be very careful. The Mental Health Act now is giving a lot of autonomy for the patients. Okay. Now coming to the implications and all, as we know, Mental Health Act is the latest 2017. It has a lot of shift in the mental health state scenario, and the very act, is to combine with the national scenario. So what we are doing centrally also from the central government point of view is to have a universality and equality in things, no? So that is the main focus. So that's the reason why the act has reformed. It was very old act, 1987 act, which has been, reformed to 2017. Now coming to the background and philosophy of this act, we understand that the act is way back 87 Mental Health Act, which has been refined and now made a new act of 2017. Why this act is because it is trying to combine with the international standards of United Nations rights of the person with disabilities. That's the reason why this new act has taken place. So why new act? Why can't follow the old one? The old one has a lot of things which doesn't give the subject, the patient, a lot of autonomy and independence. It has a little restricted laws. That's the reason why they have to reform into a new act. Now coming to the replacement, 87 Act, because they want to make it universal, okay? Because they want to combine the act to be United Nations Disability Act. It matches to that. So they have got the refinements. And coming to the alignment, they wanted to align with the United Nations. That is the reason why they have got a lot of rules. Now coming to the emphasis of the act, I'll go a little fast only, but you ask questions because there are a lot of points. I don't want you all to really sleep, okay? And neither I want to take the session, read the session word to word, so that, I want you all to be awake. So I want you all to listen and be awake. So I don't want you to sleep. So I will not read one by one, but I will take you through, okay? So now what the act says is a lot of autonomy it gives, and capacity and dignity and choice. This is the main things of the act. Now coming to the core transformation, I would like to have the mic better, because that gives me flexibility. So the core transformation is coming from patient as subjects to the person with rights. Okay. So what we are saying here is we are not talking it as a patient. We are talking them as a subject. Okay. They have rights. You recognize them as another individual with equal rights as you are sitting there. Okay. So be careful when you are uttering terms. In hospital setting, it's okay to utter them as patients, but in other scenarios, better use them as clients. Okay? So these words also make a lot of importance for psychologists. So be very careful with your vocabulary and language. Now coming to the forced treatment to supported decision making. That means they have autonomy to select the treatment they want. In US and UK and all, they select their treatment modalities. Okay? They even dictate drugs. Okay? When it comes to hospital scenarios. That kind of decision making is now given in India also. So it's quite a lot of difference, Now you are not selecting everything you want. Whether it is behavior therapy or dialective behavior therapy, whatever you want, you just can't do it. He'll ask you what therapy are you using to me. Okay, I don't like this. You better change. Then you have to change. It's that kind of decision making I am talking about. Okay, from the closed institutions to community based. That means when we are when we are having the movement. Now coming to the misconceptions, which they made it very clear. These misconceptions are very, very important because we are dealing with it in the society. So the common misconceptions before we go into the key areas is LGBTQ identity, which everybody thinks it's a problematic thing, and people have stigma saying that it is a mental illness. Many people before used to say that when gender-wise they select their own sexuality, is taken into as a crime or a stigma or a mental illness. But now the Mental Health Act defines it. It is no more a mental illness. Rather, they have a choice for sexuality, and we have to honor that. We have to respect that. So even WHO included the same, saying that it is not a mental illness, rather a normal variation of human sexuality. So this is very important for you to understand. Now, next one is marriage preferences are not mental illness. Why? Because I am telling this. It's not that caste or creed or race. People who want to stay alone, who don't want to get married, people usually say, oh, something is wrong with her. That's why she's not getting married. This kind of misconception are gone, okay? No more you can say that kind of things because it's a preference. One person has that they want to get married or not get married or marry somebody whom they absolutely in a very different way. Like say, because you are thinking about gay marriages, so many things are there, right? So that kind of marriage preferences are given importance here. So we respect cultural views, religious beliefs, and the personal choices here. So it's very important for you to understand the autonomy, means the independence you are giving to a person. So family conflicts again does not indicate mental illness. Before you used to say that disturbed family system, all this kind of stigmas were there, disagreements and disputes can be raised with the different perspectives, but they are also into the stigmatic sort of feeling that there is something wrong with the partners or things like that. So no more it is considered that. Now beliefs are not psychiatric pathology. Now coming to the village scenario, many people go for black magic. Before coming to psychologists or psychiatrists also, they go for religious leaders. Okay, and they put some mantra or tantra or some kind of religious way they go. All that is not considered as mental illness or problematic when you are talking about cultural aspects. That's why in ICD 10 or DSM 4 also, when you are talking about hysteria, especially in South Kannada kind of a thing, where some dissociative spells are there of possession and all, you don't call them mental illness, you call them religious possessions. Okay, and you accept it as a belief, and the belief system cannot be denied. Okay, then you can't make a diagnosis, okay? So you have to look at it as a bigger picture. In cultural aspects, there are many people who come and tell me, Madam, before we came here, no, because she's acting, she's falling off. So we went to a religious leader, they did some pujas and all this. Still, it is not reduced, that's why we came to you. Okay? So, that, okay? Now, once we understand what are the miscommunications of the psychiatric pathology or psychology on mental health act, now we come to key aspects of the highlights and the definition. Here they have clearly mentioned what mental illness is. See, the act is, the book itself is around 250 pages, okay? It gives huge details on a lot of aspects in detail. But I am giving you the core of the remember the definitions as they are so that you make your own judgment when you are calling it a mental illness. Or you are telling somebody that this is a mental illness. Okay? Be very careful on those lines. Now, what is mental health care system encompasses? It gives a wide range of services including diagnosis, treatment and rehabilitation and support for the individuals. Okay, so what will the state government and central government setups of mental health care do is what they do this way. So they have defined these things because to be more specific, that's all. Who are mental health professionals? They have defined even psychiatrists, clinical psychologists, and social worker also. So individuals who are trained and certified. Now see, you people are certified only. You are definitely counselors. Okay? MSc psychology goes for counseling services definitely. So which provide mental health services, they include psychiatrists, psychologists, clinical psychologists, psychiatric social workers and mental health nurses. Anybody who are trained in psychiatric spectrum are mental health professionals, including the persons who work in the ward. Okay. Now coming to the psychiatrists and clinical psychologists, you have to have a postgraduate degree of clinical psychology here. They have defined it like that. They have not defined it as RCI. They have not defined it that way. So please be careful in what they have defined. So they have defined, in contrast, clinical psychologist holds a postgraduate degree in clinical psychology. It is actually counseling psychology also, so we can take it that way. Who is enough adequately coped up with counseling and therapy services. So that's what you should remember. Now, mental health establishments are the facilities, whether government or private, they offer mental health services. Okay, it can be nursing homes, it can be community centers, it can be rehabilitation facilities. Because nowadays we have a lot of private people coming into picture where they are giving community services, isn't it? Where there is a assisted living practice for how they are doing it for dementia cases or old age homes. Same like that, community services are provided. So they are called mental health establishments. They need to be definitely under the government and they have to have the establishment, no matter if they are private or not. Okay? Anyway, we understand that government people are attached, but private people also get attached to the community centers and rehabilitation centers. Now CDCs, you know, na, classic CDCs, child centers, you know, they are all under this community itself. Now coming to the key aspects of the Mental Health Care Act 2017 is rights-based framework, okay? Then government responsibilities and clinical implications of the rights. And then I'll explain you about a case so that it will be easy for you to understand what it is saying. Now coming to the rights, very important because you need to know what rights they have. So coming to the rights-based framework, first is right to access mental care services. Without discrimination they can use. It includes timely treatment, appropriate facilities and necessary support to the mental health need effectively. Now coming to the right to community services, yes, I can prefer, I don't want to be in the hospital. I can prefer to be in a community service. So that kind of right they have. So they can prefer, the community services are essential for the individuals in mental health conditions, allowing them to integrate to the society. Now they don't want hospitalization means you have to take their word. Okay. So coming to the right to live with dignity. Now they can say that I cannot be locked up like this or be in a isolated place and all. Can be their right. So they demand respect and so they want to be living alone in whatever way they want. Now coming to the right of confidentiality, it is there in your ethics. Again, they have redefined it. See, when you are talking about ethics in counseling, confidentiality and privacy of the patient is preserved. Rights to be protected from inhuman treatment. This was there before, where a lot of abuse, neglect and degraded treatment was there for mental health people. They used to be chained or kept in a room or locked up room or metal doors. This kind of institutional practices are no more there now. They are completely abandoned, and because of the new act, everybody has to fall into place, not confining them into any secluded services. Okay? You're getting? You can stop me anywhere. Right to least restrictive environment. That's what I don't want to be in a confined environment like hospital or in a room or that kind of right they can exercise. So they can be given priority in the community services. That's what I mean to say. Okay. Now coming to the government responsibilities. See, it is right. You people have to listen. That's all. Because it cannot be other way said. I can't make it more, like a case-based study. Though I take up cases, but it cannot be that rights cannot be told. It's very important that you understand this. So establish community-based mental health services. That's what is the change, So you don't no more have lot of mental health hospitals. Rather you have community-based, where reducing the institutional care and promoting recovery from that. Okay, it includes creating halfway homes and rehabilitation centers, which are very important, where there are multiple activities, social activities included with exercises, yoga and all as a combined thing, and also have treatment of psychiatric nature. That kind of services to be provided. Now ensure geographical accessibility. This is very important because in the remote villages, mental health services are not accessible. So now mandatory rule is they have to be accessible. So that means to say we are going to get more and more establishments in a district or towns. So understand, primary mental health care services will increase. That means more opportunities for you all. So remember, so they have to give provisions. This new act will say more employment also. So ensure affordability. It's not costly. It should be very reasonable for them. Cost-based discretion has to be made. So in cities you can charge, but not in villages. That's what they mean to say. So that in community mental health services, it needs to be affordable for you to walk in and say, yeah, I have this problem. I want to get it treated. That way. Now coming to create public education and anti-stigma programs. This is an initiative by the Government Act. So if this initiative has been taken place in the society, there will be a lot of awareness programs in future. So that means to say state government, central government and also colleges which are providing the mental health services have also they have the responsibility to get the awareness programs. Like me, I am today standing here to give you awareness, isn't it? So that kind of awareness programs are mandated because it's important. It is a UGC law. It comes into picture saying that you please educate people. Okay, it starts from the institutions, right? Because you people are going to be future counselors and therapists. So that's the reason it starts from here. It can start from public scenario where districts and campings happen. To remove the stigma only, so that now the more awareness is there in cities, that's why people are accessing mental health problems. But in village, still that thing is there, How can I come? They'll say you are mad or what? Kind of a thing. So that things have to be removed. Okay, people who are educated don't feel this. People who are not educated, she has some problem and she's mad only. That's why we in a village we are not letting her. This kind of things. We don't want the mistreatment, no? So security treatments and bad treatment also is against the law. So anybody can report. No. So be very careful when you are talking about those terms, because the terms are very dangerous. They will sue you. So ensure availability of the trained personnel. This is the lacuna for us. People are saying where you will get jobs and all. You have to find jobs. There are a lot of people who want to access it. Okay, they simply don't know. That's all. So you have to barge into the societies and districts. Even today, many people, when I'm sitting in Hyderabad and working, many people in nearby towns, like districts only, like Guntur or Karnataka, they are all from Hyderabad, proximity of 5 hours, 6 hours or 8 hours. They ask me, we don't have a good psychologist with us. We want somebody. Nobody wants to go. Everybody wants to sit in the cities. And how it will be? Jobs are, when you are saying you are sitting in cities, it is saturated. People have to move into districts and villages, no? Where you sit, you put a table and sit, many people will start coming. Once they recognize your services, you will grow with your capacities. There are R&B doctors who are doing extremely well, no? In village and small towns. Okay, but that's what you want. You are to learn. Everybody can't hail for cities. You have to establish where you are and work. Okay, the opportunity is huge. We are not having trained professionals. Trained professionals are like you, who have a postgraduate degree, isn't it? R&B doctor is no postgraduate, remember? But he is giving the services. There people are going to him. He is very popular. He gets cases to us. Okay? So that kind of things. Now coming to the clinical implications, what they ask is structured plan is very essential. Cohesion must be avoided where there is no conflicts. Rights, documentation and admission is very important, and build therapeutic alliances. Now coming to the case which I am explaining is a schizophrenic case, okay, where there is a 28-year-old male diagnosed as schizophrenia. I hope everybody knows what is schizophrenia, right? How many of you all know schizophrenia? Please raise your hands. Very good. Everybody knows. Okay. You know what are the symptoms. So presently presenting with hallucinations and persecuted delusions. Okay, very dangerous. So he refuses oral antipsychotics medication despite clinical deterioration. Now there is a risk of worsening for the psychosis, and he lacks insight. Okay, but according to that, what happens? You have to give him lot of independence and capacity, autonomy and capacity. Where you say you have to do your own, you have to choose your treatment, what you want, we'll do that kind of a thing. So autonomy is given. Under this act, what happens is patient cannot be forced, cannot be institutionalized, cannot be given medication without asking them. So there is unless you can give a treatment, unless he lacks decision-making capacity. And that is again a huge documentation in the present act. Okay? And there is a risk of harm of him or others. Then only you can take measures of treating him. And the procedure follows supported admission rules. Means there should be somebody like NR means nominated representative. Means whom they choose again. I trust this guy, so I want him to be there. That is nominated representative involvement. Unless these three are met, you can't admit him, treat him, or with any kind of oral or injection or any kind. So remember this, very important. When they say, I don't want to come to the hospital, I don't want to take medication, you can't force them. You have to only counsel them. Okay? So this is the thing, very difficult. And you can't even have a fight with them. Because coercive treatment is the last option where, you force them. Okay? So what happens is, because you want to know, you are giving them a lot of independence, and only on these reasons you can treat them. That means you should understand what is decision making and what of decision making. Now, suddenly what happens is you are doing a capacity assessment. It means you become, a human MRI who is, scanning the patient right from, top to bottom in 30 seconds. Can't be that way, right? So, you're not going to be that, but you have to assess him in a very systematic way. So, coming to the thing, first understand illness and treatment. This involves the grasp of essential facts. Understood? So, you need to know what is happening with them and what implications are there for the treatment. Now, appreciation of the consequences, accepting or refusing the treatment, you have to accept it. If they say, I don't want to take medication and I will kill you, but then I will not take medication, this is how he says, you still have to accept it without saying anything. The only modality is to counsel. Okay? Unless the decisions impact their health, safety and overall well-being, then only you are taking. So reasoning about the choices, whether the patient is reasonable or not, okay, whether he is reasoning it out, you are understanding, you weigh the pros and cons of various treatment options. You tell him, you take this, it will be good for you. Maybe this also is there, this also is there. You are giving alternatives. Maybe you can go to counseling, you sit and talk what your problem is. Maybe you will figure out some kind of treatment modality. This is how you can explain the patient. This happens mostly in the mental health services, where you are posted in a district mental health setup or a primary mental health care setup, where the patient comes and you're supposed to counsel them. And a lot of counseling goes tomorrow. I'm telling you, it's not easy. It will be too much, because if they are refusing treatment, it becomes the psychologist's job to agree him for the treatment. So that's how the psychiatrist works tomorrow. Okay? Now, communication of choices which you have to do in spite of, I told you just now, these are the list of choices which you have to do and all. So for everything, counseling is required. Don't think, counseling is not required and we don't have jobs and where we are going to fit in tomorrow. Tomorrow, you are everywhere. Let me tell you that. Because this autonomy is very dangerous thing. Okay? The independent choice making is a very dangerous thing. You remember that. Now though we are forcing our family member or a friend, no, you go to psychiatrist, you take this medication and all. Or forcibly you take him and put him into a de-addiction center. But that is not going to happen tomorrow. Very, very careful. So everything they have counseling only as a modality, as a resort to save them. Okay? So even in our hospital, it's a very big setup where I work with a general hospital setting. Okay? It's called Krishna Institute of Mental Sciences. You have such huge bills, no? Even they have many financial counselors also. Everywhere counseling is going. Okay? To agree them for the treatment, counseling is going. For paying the bill, your counseling is going. Okay? For staying in the hospital, counseling is going. Everywhere it is counseling. And we have this heart and lung patients. They have a lung transplant and also they have lot of hospitalization. To stay for hospitalization, to follow the procedures, also counseling. The sisters are doing, we are doing, doctors are doing, everybody. They feel the doctors are not sufficient, they call the psychologist. Madam, he is not walking. So lung transplant happened, post-surgery, not walking. They are afraid. Because if the transplant took place, now they are very fearful. They don't want to walk. If they don't want to walk, the breathing doesn't take place normally. Okay? If they don't want to walk, the procedure is failed. So they are afraid, 40-50 lakhs of surgery it is. What will they do? So they will call me daily, you come twice or once. Every day you come and counsel them till they walk. Okay? Once they walk, they are fine. Again they will have some problem, they are not eating well. Again they it's important for you. We have to tell like that tomorrow. Risks of treatment procedures. Okay, so every department will start coming up with these things because where the saturation is going up. In cardiac also, a lot of relapses of heart attacks. So what will they do? They don't want so many relapses, no? If they have relapses, what will the cardiologist be said? He's not a good doctor. But he's a good doctor. But the relapse is because of you. Your lifestyle is bad and you are not following what the procedures of what the doctor has said. So you need additional counseling. Again, counseling it comes from. You're understanding? So every sector has counseling tomorrow. Every sector. And now kids rearing, parenting styles also changed. You are giving a lot of autonomy, no? So you can't punish them, you can't hit them, you can't scold them, you can't be shouting at them. So this is a problem in schools. What to do? We can't tell them, madam, they are like this, they are not behaving well. So a lot of behavioral problems. You are understanding? Okay? So communication of choices. Now coming to exploring the second one, non-coercive alternatives. Now this is all in decision making, remember. All the points which I am telling is only for decision making. Okay? Now you do psychoeducation. Now psychoeducation, tell me a field where there is no psychoeducation. Now everywhere psychoeducation is there. Very, very important. It involves for you to tell very clearly what it is. Whether it be any medical procedure, medical treatment, anything. Outside also, even in corporate offices, everything you will be requiring psychological services. Remember, everywhere. Okay. So this thing is very important. To understand psychoeducation, so I am not giving. Now involve the normative representatives. See, normative representatives are who the patient trusts. No. Usually, what happens when the patient is brought to the hospital, he is the least trusted person. Who gets the person to the hospital is the least trusted. Okay, but you want the patient to choose the normative representative. So what happens is it can be anything. See, I am seeing nowadays in hospital setting, they get their friends as normative representative and cannot say anything because it is whom they trust. It need not be family people and all. The corporate girl gets admitted in our hospital and says, my friend is a normative representative. So we have to accept that because whoever they trust. So you don't discriminate. If at all this thing is not there, who else will be? The secondary thing will be whom they trust is family. Okay? You have to then select the family members who are close to them, are the normative representatives. Now coming to the medication alternatives. Now they say, many people who come to me, I diagnose them for depressive disorder and say you have a depressive disorder and it is little pretty severe, you have to go for medication as well. So I tell them, see, therapy, we will do CPT. Along with that, comorbidity, you take another, medication line also. So treatment modalities, I tell them. Then they refuse. They say, we don't want medication. We don't want to work on medication itself. We'll work on alternative medicines. There are many people who are opting nowadays for alternative medicines. People are very happy to take homeopathy, Ayurvedic, Ayush kind of things, naturopathy or something else, but not the psychiatric pill. Okay, because they feel it's drowsy, it doesn't let me perform. So I rather go for therapy. Okay, so then you have to respect it. But sometimes it happens that their reasoning is distorted. Now, a schizophrenic comes who keeps saying, I have, suspicious thoughts on my wife and all, and he is continuously troubling in the house. Then you tell the family members, no? Then you involve the family and and tell them no, better to have a treatment, it will help the thoughts to be sorted better, that kind. So behavior engagement approaches where you are motivating. I'm saying this because this is the one which is there in every sector of life, where you have motivating interviews and rapport building, where you encourage the patient's concern and also give the alternatives. So again, counseling is a part of this kind of laws which they are keeping. Now coming to the evaluating the risk and needed supportive admission. So you are talking about decision making only here. In decision making you have so many parameters. So this is the third step where the patient can't take a decision. Now we are talking about anxiety disorders, depression and mild schizophrenic aspects, because I have seen some of the educated schizophrenic patients who come with distorted thought. They will tell me, I have an insight that my thought is not correct and I am seeing some hallucinations which are not real. And they told me in the house, my siblings and my mother and all told me, you are wrong, you are not, I am not seeing anybody, you are only seeing. So that way, they get fearful and they come and they ask for treatment and they get treated. So these are the people with good insight, no? Now we are talking about somebody who doesn't have insight already. So these are the people who have a risk, and risk to us also, they keep hitting and all. So access to supported escalation need for admission. Now here we are escalating an admission where the patient is very difficult, he is become, he lacks decision making, and NR involvement is important. Whenever I am saying NR, it means nominated representative. It can be somebody who he trusts and takes a consent. And then huge documentation, documentation of forms, signs, and then a lot of documentation of what capacity he is, decision making. So it's nothing but a cardio workout for your fingers. So you have to document. Okay? So how many people write more when the patient is saying something? Anybody did that? People who write? Raise your hands. Who write when the patient is talking, verbatim, and noting down things. Nobody? Then you are not compliant with MHCA. Oh, you are already compliant. That means you are already compliant with the Mental Health Act, because it says document. It says document verbatim. Okay? So all these people who are not doing, better get into the habit of writing what he is saying, or else you will be in risk. Okay? You have to write, informant told this. Okay? Self-reported. This is very, very important. You have to mention the father, mother, sister, or friend, whoever it is. So you will be complying with the MHCA Act if you are writing, documenting. So it is very important. Now coming to evaluating of decision making. Now this person can't evaluate, then you have to understand his ability of understanding about the mental illness. He says, no, I don't have any problem. You treat my wife. I'm not having any suspicious thoughts. He'll say that, no, that is where he lacks the decision making. He'll say, everything is wrong with my parents and my sister only. They have brought me here. I didn't come on my own and I don't want to come also. I have nothing wrong with myself. He'll say it that way. So that kind of things. Now coming to the ethical and the clinical balance, balancing rights and safety. This is also step 4. It's very important. While taking decision making and many other things, you have to keep these also in your mind. Now respect the patient's autonomy, where you give choices, you give their treatment modalities and say you choose. Okay, some of them are very comfortable in taking tablets because it's a quick treatment. Now some people who are in corporate world, they'll say it's better we take fast treatment process. If we can't handle our therapy, we'll come to therapy. There are people like that also. Okay, one lady who was in middle age, quite successful, but then had a lot of conflict with marriage, but came to understanding that I don't want to solve this problem. Okay, she came to me. I said, how am I to help you? She said, first help me out. I want to enjoy my life. I want to not have any, rupture with my husband and have thoughts of my husband. But you're living in the same house. Oh, you're living there parted ways. So she says, I live, but emotionally I want to disconnect. Okay, I want to disconnect and work. I said, okay, I will help you out in working with your own independence of thought process, where you be little unattached. It's not that you have negativity, but rather unattached and work and be happy also. Not get bothered with his actions. Like he'll sit in that room, he'll keep TV and keep watching. I get very irritated. where he can refuse a treatment. So we are talking here with severe depressed 45-year-old male with severe depression with psychotic symptoms. Okay, how severe depression will present very sad and things like that, and also have psychotic features. So has an advanced directive where now he refuses ECT. Okay, ECT is a choice for severe depression, isn't it? Now for severe depression, ECT is the way to treat them, get them out of the scenario. Then what you do? Okay. Now you have to respect their advance directives where they said I refuse ECT treatment. So here comes the legally abiding unless overridden. Okay. When you can override, you have to have another documentation and aspects. I'll come to that. Now you have to explore no alternatives. He says no ECT. Then you have to say medication is the line to go. You have to say psychotherapy doesn't work, very difficult, but still you have to tell the possible aspects. Now, how many of you all know RTMS? RTMS is a machine which stimulates the dorsolateral frontal areas and all. It's a brain kind of small shock is given with an electric shock kind of a thing. Very small, it is not like ECTs. Even you can do it. I have been a person to see how it is done, how they stimulate and all. It's a very small procedure, but then not like ECTs where it goes unconscious and all. It's an easy procedure and tolerable. So that can be given an option. So tomorrow we'll have a lot of digital aspects tomorrow coming into picture where you can choose those fields for treatment. So now when you can override, when it is only life-threatening situation that they will collapse and they will go into bedridden kind of a things where you have to handle them and no alternative effectives are there. Now medicine is not going to work on this patient because there are a lot of negative symptoms of depression. Then you work with them. And there is a clear justification exists in proper documentation. Then only you can go to ECTs. Now this is more for psychiatrists, so I will go a little faster only. Legally prohibited procedures we call it. ECT without anesthesia is banned now. Okay? Because it is a harmful thing and it is very, before they used to give, and I have witnessed also as a student, it is, we feel very unethical sometimes that giving ECT like that directly. So now it is banned, it is completely prohibited. You have to give anesthesia and give a ECT. Now ECT with the minors also has provisions. There is a lot of approval where MHCA Act accordingly they have to take approvals and they only give for minors. And then you have seclusion ban where you cannot keep them in isolation because he is severe depressed and psychotic. And you restrain to resort kind of rehabilitation community based. Okay, you people settle, then I go ahead. Come in the front, there are some chairs in the front. Some of them occupy in the second row. Fill the blanks, come in the front. Come in the front. 3 of y'all can come in the front. This side. Take out the bags and keep it down and sit. very, very important. If we don't know from where things are spurred and say allegations may take place and sue you. So government can, if it goes to suing and putting a case against you, very difficult. If you don't have any documentation, you can't prove yourself that you are correct. Okay, so documenting becomes very vital. Okay, so remember that. So whatever decisions you are taking also becomes time-based and very specific. Now consent must be informed. It is free and written consent will be there. So informed consent is legal. So even in online you have a legal consent. If they are permitted only, there is an ethical requirement of any medical treatment which you are giving. Okay. If it is a hospital based, very clear that documentation and scanning is there, where you are going to have document everything in written. But if you are not, then how? You have to maintain files. You have to maintain files. It's very, very important. Okay? And whatever information is provided by the patient, you have to write it down, document it well with the written format. Then we are talking about the case where bipolar mania who refuses to have treatment. Okay? So bipolar disorder, as you know, manic people, they are all in elevated self. They are not what we are thinking. Decisions cannot be taken by them, but they lack the capacity of it, and they have a lot of disinhibition and all. Now, family concerned about the safety. So what happens with MHCA approach is they access the capacity of it. Now they understand whether they understood the illness or not, the admission process, because it needs to be admitted, no? It is like that. So whether this person is impaired reasoning, this kind of capacity building is there. Next step is whether he is lacking capacity or not, and whether he can involve the nominated representative whom he trusts. Now he says, yeah, we came with the family or mother, he trusts. Then we take them into account when he lacks the thing. Okay, then you document the capacity findings, the risk profile. The documentation becomes very, very important to say that he lacks the decision making also in treatment alternatives. Okay, that's why we are involving a nominated representative is very, very important. Got it? No, it's like our phone icon, where the phone battery icon. It is charged and all. If you are making a decisions, if how charged you are, it matters. If it is not charged, your decision making and reasoning also are not charged. That way it is, okay. The capacity finding or the capacity assessment is like how charged you are in reasoning abilities. That's what it matters. Now emergency treatment, how much is the duration of treatment? Only 72 hours. Means how much? 3 days. That's all, right? You have only 3 days to treat him for the critical condition. If you can't treat, you have to send him home. There is no other go. Okay? So it's very, very important how maximum you can take the duration of time for acute risk to the patient or others. Okay? Now coming to the documentation of severity and risk is very important. Involuntary admission highlights where independent admission can be permitted. As I said, there are some corporate patients who come directly to our hospital and get admitted, saying that I have a problem, I am not able to go, I want to get admitted and get themselves treated. That way, you have independent decisions where patient can voluntarily come to the hospital and say, I have something wrong with my brain, I want to get admitted, and they admit and work on him. Whatever treatment modalities he agrees for again. So that way. In supported admission, they will get somebody like a friend or a nominated representative and get themselves admission. Now challenges in implementation. Now what happened? First, few documents which we have pursued with the Mental Health Act are our right function the way we are. So as I said, by the time the patient comes, you document everything and you finish and you pass the file. The patient is already recorded and he runs away. He goes away. Okay? So this kind of things can happen with our system. Now infrastructure lack of, that's what I said, no? In rural areas and semi-urban areas, there is an infrastructure lack. They lack the physical resources to take the patient to delivered mental health care services. So this becomes pleasurable for the government to put primary mental health services even in district and town and rural places. Okay? And you sit there and work. Not enough trained personnel. Now when we are going to rural areas, we don't have trained personnel, as I said before also. Okay. Now coming to the clinical challenges, what happens is we have a lot of burden in documentation. By the time we do it, we have no time for the treating of the patient because we are only writing documents. So where is the time to treat the patient? It becomes like that. So it's so much of writing of include progressive notes, advanced directives, and involvement of normative representative. All this you are supposed to document. Okay, so this becomes problematic. There will be conflicts with the independence and safety. Tomorrow you have, a lot of confusion. We are giving so much independence to the patient. Oh God, now this fellow will hit me, then what will I do? Okay, this kind of problems you may face when it comes to the documentation conflicts also. Only in emergency situations you can often take a action. So there you can say like violent patient, for example, is coming. Now he is very violent and he is hitting there is a risk. Then what does an MHCA do? It says that if this emergency person can be tranquilized for 72 hours only. Okay, after that he cannot be tranquilized. Okay, to prevent harm. Now emergency person, they will say you take action when the person is hitting and when the person is doing rubbers in the hospital. Then the MHCA people will say, okay, we don't want to have this WWE conflict, where there is fighting going on, no? That kind of scenario they don't want. Then they'll say we'll take action. So this is how our MCH Act is. So when somebody is hitting and doing a lot of problem, then we can immediately tranquilize him and we can then take the necessary action. That's what it says, okay? But then also you have to record why you are tranquilizing him, what is happening, what is the decision making he lacks, who is the normative representative, what is the advanced directives he has written before. So this accessibility also is very important. All this you have to document and then take the steps of violent patient. So it becomes very, very important and difficult, I'm telling you. Okay? So balancing rights and safety becomes a big question mark. Where what should I do with this patient now? He is having so much of problems. See, in US this was the thing, United Nations Act this is. So in US many people refuse treatment and they are, when we are going in the street there must be a schizophrenic right beside you who is just standing, okay? Suddenly gets very angry when you keep a face like this. Okay? So they may be reacting. See, because once I went to Walmart in US, not Walmart, IKEA I think, and we were ordering some food. And you know how Indian people are very expressive. They put faces like this. I was with my sister nicely putting on, oh, not this, not that. That kind I was going on with my own playfulness. There was a black person who was serving me. He immediately said, what is wrong? Is something wrong? And all, he got very serious. Immediately my sister said, don't keep the expressions. Keep a neutral self. He is getting very annoyed. So I immediately put a neutral self and said, no, nothing wrong. And I maintained my face like this. So kind of a thing. It can happen to you even in bus stops or in malls, wherever you go. So people maybe everywhere, if they are given this kind of autonomy. Okay? Wait for a second, it will reconnect it back. Because it's too many points, I can't remember myself. Even Nathan, I want you all to, doze off also. So to put up with this kind of so many act laws is very difficult. But it is very important for your clinical practice tomorrow. Taking informed consent, legally abiding, and also documenting becomes very important. And you have to preserve also for more than 5 to 6 years. So think about the documentation, how much you will be, keeping it as a preserve also when you are seeing cases. Okay? It's coming.
Live.
So balancing rights and then cultural context where stigma is there for advanced directives and nominated representatives. Integrating the act into daily practice. So this becomes very important. Now we are coming to the actually building a right-oriented clinical environment to the people. Now provide written rights at admission itself, where you give the patient the written rights at the admission. Okay? Or when they come to you only, you provide the choice of medication, therapy and all. As I said before, see, they will say, no, I don't want cognitive therapy. See, because nowadays I see a lot of OCDs who will come and say, no, I don't want exposure therapy. If you are doing exposure therapy, I am going. I don't want. Okay? Because they are so scared. They don't want exposure. No, but exposure is the right kind of therapy for the OCD. But they don't want it. What can you do? You have to explore alternatives only for them. Isn't it? They are very threatened. If I tell them, no, you go to temples, I have class members' thoughts when I go to temples. Means you have to go to temples every day if I say. They are not liking it. They'll say, I will not go. I will not do this. So that then we have to, work with the different options of therapy. This is what happens not only in psychiatric care, but everywhere, even for therapies. Okay? You maintain privacy and then you maintain the daily schedule. So you strengthen the documentation practices. As I said, no, you have to use templates for capacity assessment and all. So this becomes very important, document of decision making. All this. So you improve communication. So it becomes a challenge for you psychologists to talk what is right and use simple language which is understandable. Okay? If you speak jargon, this, that and all, the way a US person elaboratively says one small sentence into 5 different sentences, it becomes very difficult for you to understand. Finally you put it on the bush and say, this is what you want, right? That then you understand. So for you have to use simple, good language, which is not a jargon. Then involve family at the earliest because it is safe for you. You don't want to get problems with this guy. So better involve. You tell them, please get somebody you trust, somebody like a family. Okay? There are some clients who come who are independent living, no? They will say, I don't have anybody. I don't want to get my family involved. I'm coming alone. So I say, you try to get your friend whom you confide or talk to, somebody trusted who can see you outward. So very cleverly, psychologists have to put in a way that, we are collaborating information. So we want somebody who sees you on the outside front. You are very subjective, isn't it? So I don't want that bias. I want somebody to come and collaborate information. This is how I tell. Okay? Because if they come alone, and they are very borderline personality aspects, very difficult. But these people we cannot trust one way. So we want somebody to come and tell us how they are also. Then I very cleverly put them saying that safe. You are in a safe mode, okay, tomorrow. Whether it is a family or anybody, nowadays it will not be so much family. So apply the least restrictive principles, community-based alternatives are the thing, and then minimize of physical restraint. We cannot do anything. Develop systems for AD. AD means Advanced Directives in Emergency Care. Advanced Directives I can give you today also. I myself can give. Not you. Anybody can give that way. So this advanced directives, they are asking for centralized database. So what happens if this act has come? Slowly it will digitalize. Okay? See, think about the future vision when an act is coming. That means everything will become digitalized tomorrow. Everything you have to type in the computer for digitalization. Though paperwork is there, you still have to do it digital. Why? Because that information has to be accessible to any hospital. Now this fellow is coming to a primary mental health care services. Tomorrow he has become very violent. He is going to a secondary tertiary center. Now tertiary center has to understand what is his advanced directives, no? As he said, I want only meditation and biryani or something like that. Whatever he has written, we need to know. Isn't it? So that way, data accessibility they are asking for tomorrow. It has to be centralized. That means tomorrow everything will become digitalized. So corporate governance or medical governance is going to take over things. Very, very important to know. So emergency protocols are there. In conclusion, what is the main thing? You have to, respect the rights. You have to respect the capacity assessment. You have to see the nominated representative. You have to even look into advanced directives, what he said before only. And then, you have to document each and everything. And also find time to treat the patient, okay? After doing all of this, you still have to find time to treat him also. So this is what our Mental Health Act says. Okay? Thank you. Thank you for patiently listening. Actually, it is very difficult subject what we have touched upon today. Very dry. Need to remember lot and lot of points. Okay? And these all, mind you, I'm giving iceberg kind of a thing. So there are a lot more. Iceberg means it is only tip of the ice, no? Tip of the ocean. So there are a lot of details. 250 pages they have given that. Very not detailed wise they have been told. It's very important, but the most important ones I have told you. Remember rights, capacity assessment, nominated representative, advanced directives, okay, and then documentation. These 5 key notes. Okay, thank you so much. If you have any kind of questions, please be free to ask.
Now the stage is open for discussion.
Yeah, please.
Ma'am, you told about the autonomy part, but do you think that, no, it's just a thought, but do you think that too much autonomy can be a risk to the society as well?
It is very risky. That's why I'm warning you at every juncture, every point I was saying. Very, very risky. Because that's why I said somebody may be just beside standing, he may be a schizophrenic or a manic depressive. You really don't know.
Do you think that there should be some bar or that loophole should be checked in this act?
But that is the autonomy we are giving to the patient, no? We are not treating him as a patient, no, we are treating him as a subject. So we are difficult, but have no debate on that. Because this falls into line with the United Nations Act also of disabilities. So they want to respect the person who has any kind of disability tomorrow. So we can't say anything about it. It is risky. It is risky in our society also. That's why I said, no, in US and all these directives are very clear. That's why they don't she was telling me about a case where he has come for the visit, which was, has an appointment and the visit is predefined. So he came, he took off all his clothes and said, if you give me breakfast today, I will wear my clothes, or else I will simply die. Okay, they were telling him, please wear clothes, please wear clothes. He was not listening. He said, get me breakfast. They had to get the breakfast. Okay, they had to give him what he asked for, then only he wore clothes. All this happens. So when you are giving that much, you don't know. These are the things future where you can see anything. Okay.
One more question is, in US we have seen different insurance policies regarding mental health. Do we have anything in India for the extreme cases at least?
No, only private institutions have now, which are catering slowly. But still, psychiatric problems, there still is a illness. We don't have clear-cut insurance plans. But tomorrow, the national aspect is to get insurance on all the medical aspects, slowly. Then mental health also will be a part and parcel of the medical aspects. So that is it.
Thank you.
Anything more? Yeah, please.
Again, it's about autonomy. So my question is that, as you know, the client here has every right to discontinue or refuse the treatment.
Yeah, very much.
Just like taking a case, maybe depression or something, where they are in a moderate or a mild stage, and they are refusing the treatment, and they go on with their life in a normal way, and they somehow end up in a more severe state or an increased severity. And then if something, a self-harm or a harm to others happen in your life, taking it from the mental and professional point of view, how will that affect them? Because as of now, if
How will that affect the?
if I'm a professional now and I'm treating a patient, maybe something happens to them, legal aspects, I will be maybe called in, right? So for the legal aspects as well. So for them, how will that be counted?
So yeah, this is very important because you have to depict that. If he is refusing treatment and he says I will discontinue, you can write it as well. That is discontinue. Okay. If he says by his mouth, there are many people who don't say and just stop coming to you. Isn't it? This happened with me with one of the case. Okay. The patient came with severe pain to orthopedics. Couldn't walk, okay, he was on a wheelchair and severe pain, psychosomatic pain it was, and I saw the case because they sent me from orthopedics severely because he's not walking from 1 week and he's a professional. When I spoke to him, I understood that the wife was actually into depression and his psychosomatic pain was due to the wife being close to one of the colleagues in the office. Okay, they have this person is little possessive and too much suspicious about the wife. He didn't have any psychiatric problem, but the only thing is his personality was like that. So he was observing and monitoring the wife, and the wife was having a friendly relationship. That's all. Not much also. They didn't exchange even WhatsApp messages, nothing. But he started, accusing the wife, and they had a huge marital discord, for which he fell into problems of unable to walk and severe pain and all that, because of the stress going on between them. But in the process, I was seeing, in the process, I understood the wife was suffering more with the depression because of his accusations. Okay, and she came and cried with me in such a way that, if this things what happened in the office, if he starts telling that to my parents, my both siblings will not get married. She was afraid of that. Okay, and my life will be ruined. Okay, now he is accusing me of this, but he should not tell it to the parents. So and she cried so much. I felt very, the way she was presenting symptoms were so severe. I called both of them and warned them. she's suffering from pretty good depression, and she's not having good mental health, and she's also thinking about suicide intention and all, is high. I told and spoke everything and sent them. And told them to come in the next day only. They didn't come to me. 2-3 days passed. He suddenly ends up with me in the hospital saying that she has committed suicide. Okay, he doesn't want to tell his part. He would have given some accusation where in the house when he was present in the morning at 9:30 kind of a thing, she just went inside the room, locked the room, hanged herself. Within 15 minutes she is dead. Police came running and he came running to the hospital, save me kind of thing. Okay, because he asked me to save, I said the only help I can do, because here no one will ask me anything. You go get yourself admitted into psychiatric hospital, then with the admission nature they will not put you into the jail. And later you can think what will happen and resolve the case. So every time you are safeguarding the person only who seeks help. We are not harming the patient no matter what he is. Okay? See, we don't know the actual details whether he has told anything to his wife or not. Why she felt. It was she herself took the decision or he told something, we really don't know the whole scenario. We can't assume and work. Neither we can accuse the person who comes for help to you. You understood? You are not blamed anywhere unless, you are involved in the case. So the people here, I was involved, isn't it? Police came, spoke to me about what he is going through, whether we can put him in jail with this condition or not. That's all they asked. Because it was a legal case and he needs to be first action for suicide committing, not attempting, committing. She has died, no? So they first arrest the people in the house who are responsible. They interrogate. Okay, they don't put them into institutionalized and all that, no? It's only a matter of temporary nature. So in that way they only ask you. But you won't be into soup. You will not come to the court of law and also be stood in the bone. But then certain cases, yes. They will ask you to come and tell, depending on the nature of the case. Okay? So you have to be careful, that's all. Then, what else? Any more doubts on the legal act or how you have to go about your counseling? Tomorrow you will be counseling a lot of cases. So remember very well how you have to do, what you have to talk, what you should not talk. Do's and don'ts, very important.
Ma'am, I have a doubt. So you told that the decision making done by the mental health board is delayed a lot. So as a practitioner, how can we tackle that situation?
As a practitioner, if at all you know that their thought distortion is there, he is unable to, comprehend what you are telling, then you have to involve the normative representative. That's what the board is saying. Because he lacks the ability to take decisions and his reasoning is distorted, you have to tell him. So proving will become very important. So many times what we do is put them into psychometric assessment, where Rorschach testing and all are done, where you can clearly say distorted reasoning or distorted thought process and all are there. That is diagnostic testing. Another one is clinical testing, where you clinically say this is what he is having symptoms. Then you have to involve the normative representative, okay, who is a family member or a trusted person with him, and take him into confidentiality and tell them what is happening and say the importance of treatment. There also again he has the ability to choose. It's very difficult. It is going to be very challenging tomorrow, no matter what. So objective assessments will become more important. Okay? So objectively you have to prove, no, you are not fine. Kind of thing. Okay?
limitation with respect to that?
It is very limited, but they say no, we are trying to be in par with the international standards. So we are trying to be, universality is the goal now. We are trying to be equal to all other countries, isn't it? It is very risky, but we have to accept the law and work with psychological services, but then they are giving the alternatives also. See, alternatives are like a lot of counseling will go into these patients tomorrow. Because autonomy has increased, a lot of counseling will go. So that's why I am saying there will be more need for you all. Okay?
So you could see in most of the cases, ma'am, after once they label it as in the victim or something, in the criminal, it's proved that they are the criminal. But still they will consider the being into the mental illness as one of the option for them to escape from the punishment.
But then the laws also are very rigid. They are putting everywhere objective assessments and subjective assessments, and a detailed clinical scrutiny is done. If it is criminal aptitudes, okay, like violent patient and all, definitely they will work on this kind of patients, no? So there is, when a lot of documentation is there, there is no slippery. You are understanding, no? You are taking from many sources also the documentation. And verbatim you are taking. When verbatim you are taking, it is understood. Okay? We are talking about a patient here. Forget about the patient. We are talking about somebody who is normal only. In spite of being normal, they will talk something rubbish. At times losing their, temper and whatever in offices and all. They have taken very serious, I have dealt with one case in central government. She has spoken something to the director. Okay. Her case was, she spoke that you have an entire kind of a thing she spoke. That too in a very high placed person, if she speaks like that, it was taken into charge. Okay? That scrutiny took place and verbatim recording has taken place and she was made to sit and the cross question, okay? The information was collaborated with 10 other. All this was done only to tell her you need treatment. You got it? So this kind of things also happen. So there was certain distortion for her. All of the radial is normal. But in spite of that. So imagine somebody is abnormal only, then we are easy. We are easy to diagnose him and say, okay, you are like this. There is a risk, as you said, there is a lot of risk. We need to work. We don't know who, walks into your clinic tomorrow.
Since we have all those action limits and many things to follow in the counseling procedure. When it comes to autonomy, definitely will be in question whether to implicate this or not.
Very true. Because residual schizophrenia I was treating, he suddenly became very violent in my room. I was scared because I was doing a therapy for him for 1 year. He was very highly placed father. He was in a very high position in police department. And the son is schizophrenic. He was very nice, happily, he liked me, he searched for me. I was seeing in a government setup before. After 10 years, he searched for me and came to me only. And was taking therapy, he was doing well. Suddenly this burst of symptoms happened. He tore his shirt in front of me and banging the table and all. I was so perplexed. I didn't know it was a confined room, no? I was scared. Slowly somehow I came out, but he didn't stop shouting. Okay, this kind of things are very scary. And slowly then he was taken into psychiatric care and all that. Because his symptoms suddenly shifted. So all this will be, see, because I know him, it is easy. What if you don't know the client? And he comes for first or second visit. You need to know how to access help for yourself also tomorrow. Okay. Any more? Yeah. issues. If you want, for me, don't ask me. I'm not going to admit no matter what you tell me. Okay, I'm not going to give you any written consent. It is up to you. Then they will seek some other clinician and specialist for them for admission. But the Act says no. So if there is some legal problem, they will be at so. So from your point of view, you refuse.
But at that same time, consider the humanity patient.
See, humanity code is legal. Okay, humanity is definitely the grounds. And you give the option, no? Here you giving option only is your humanity. Not going beyond your limit. Please be very careful. I am going to help go all the way. I am going to support him. I am going to take him. Don't become normative representatives. You are no way concerned with the patient. Please draw your line. How much you are asked for. Okay? So your humanness works only with giving your options. Giving what is to be done. Now, as I said, one suicide patient, she's committed. I feel so bad. I really was shaken for 2 days. I felt so sad about that girl because I was so having the sixth sense that she will do something. So I want, without me knowing that sixth sense works sometimes. So I want that fellow also, very much. I want even the family. I called them, I said, don't say anything to your daughter-in-law. Please leave it for another 1 week. Her emotions are very heightened. We really don't know what will happen. She's having too much of suicidal aspects. It's very difficult. She needs treatment. All this I told her. We can do only that much. More than that we cannot. So remember your limitations. Don't go beyond. And put forward your own aspects of no, I can't do this. This is not in my purview. And this is not legal. I say by abiding with your duty and laws, you are very good human being rather than going forward and doing something. Okay? Beyond duty, don't do. Okay? What else? Yeah? Thank you so much. Thank you for quiet listening and good interactions also. I thank the organizers once again for calling me here for a wonderful university. Thank you so much.
Thank you so much, ma'am, for an insightful and thought-provoking session. I am sure everyone will gain valuable knowledge and new perspectives. Now, I request Ms. Aishwarya to offer the vote of thanks.
I take this opportunity to express our sincere gratitude. First and foremost, our heartfelt thanks to Dr. Shanmughi for gracing today's session with valuable insights and for inspiring all of us with his expertise. I would like to invite Ms. Ashni H. to hand over the certificate of appreciation. Our sincere gratitude to Professor Vishwanath P, Principal, Dr. Soumya Devi, Dean, Dr. Vandana J, Head of the Department Psychology, and Ms. Ashini H, Staff Coordinator, for the constant support and encouragement. I thank all of the teaching and non-teaching staff for making this session a successful one. Finally, I would like to thank all our students and participants for your enthusiastic presence and active involvement. Your participation truly made this program meaningful. Once again, thank you all for being a part of the session and making this a wonderful program. And have a wonderful day. So now everyone can move to AV12 for a tea break, and after that, every participant of the fest is requested to go to their respective venues
ഞാൻ കൊടുക്കാട്ടോ.
ഒന്ന് പോയി തരുവായിരുന്നു. പോവാൻ പറഞ്ഞില്ല ഞാൻ എടുത്തു.
ഹലോ, എനിക്കറിയൂല. അവൻ കുറേ ദിവസമായിട്ട് ഭയങ്കര ദേഷ്യമാണ്. ആരടുത്ത് സംസാരിക്കാൻ വേണ്ട. ഏട്ടൻ നേരിട്ട് ഇങ്ങോട്ട് വന്ന് സംസാരിച്ചേക്കൊണ്ടെടുത്ത്. എന്നാ വാ പോവാ.
ദിയ, സാറാ
താങ്ക്സ്.
ഒട്ടും പ്രതീക്ഷിക്കാതെയാണ് ചില മനുഷ്യരുടെ ജീവിതത്തിൽ പല മാറ്റങ്ങളും സംഭവിക്കുന്നത്.
മിസ് ചെയ്യണ്ടല്ലേ? എത്ര അടിപൊളിയായിരുന്നു നമ്മുടെ പഴയ കാലം. എല്ലാം നശിച്ചു, നീ നശിപ്പിച്ചു. കൂടുള്ള എല്ലാവരും നിന്നെ വെറുത്തു, നിന്റെ നശിച്ച ഡ്രഗ് യൂസ് കാരണം. എന്ന് വെച്ചെല്ലാം അവസാനിച്ചു എന്നല്ല, നിനക്ക് കിട്ടാൻ പോകുന്ന ഒരു ഗോൾഡൻ ഓപ്പർച്യൂണിറ്റിയാണ് ഈ വരുന്ന യൂണിവേഴ്സിറ്റി എക്സാം. ഇതിൽ നിനക്ക് നല്ല മാർക്ക് സ്കോർ ചെയ്യാൻ കഴിഞ്ഞാൽ നഷ്ടപ്പെട്ടതെല്ലാം തിരിച്ചു പിടിക്കാനുള്ള ഒരു അവസരമാണ്. You better don't miss this chance.
Examination result comes and the first rank goes to Noel Matthew. Mistakes happen, it's all human things. But being trapped in it and forget the reality is nothing lesser than having a life in hell. Sometimes all they need is someone to hold, someone to stand beside them, someone to understand and try to pull up them from the loophole. A helping hand.
ಈಗ ಬಂದ್ಯಾ? ಹೋ, ನೀ ಫ್ರೆಶ್ ಅಪ್ ಆಗಿ ಬಾ, ನಾನು ಟೀ ಮಾಡ್ತೇನೆ. ನೀವಿಬ್ರು ಚೆನ್ನಾಗಿದ್ದೀರ್ತಾನೆ?
ಹಾಂ, ಚೆನ್ನಾಗಿದ್ದೀವಿ.
ಶರತ್, ನೀವು ಇಬ್ರು ಚೆನ್ನಾಗಿದ್ದೀರಿ ತಾನೆ?
ಯಾಕಮ್ಮ ಹೀಗೆ ಕೇಳ್ತಾ ಇದೆಯಾ? ನಾನು, ನಮ್ಮ ಗಂಡ, ನಮ್ಮ ಅತ್ತೆ, ಮಾವ ಎಲ್ಲರೂ ಚೆನ್ನಾಗಿದ್ದೀವಿ.
ಮತ್ತೆ ಏನಿದು ಕಾಲೇಜ್ ಹುಡುಗಿ ಥರ ಇದೆಯಾ? ಮದುವೆ ಆದರೂ ಈ ಥರ ಇದೆಯಾ? ನೋಡಿದವ್ರು ಏನಂತಾರೆ? ಕೈಯಲ್ಲೊಂದು ಬಳೆ ಇಲ್ಲ, ಹಣೆ ಮೇಲೆ ಕುಂಕುಮ ಇಲ್ಲ, ಸರ ಇಲ್ಲ, ಈ ಥರ ಬಂದಿದ್ಯಾ ನೀನು. ನೋಡಿದ ಜನ ಏನಂತಾರೆ ಅಂತ ಇಲ್ಲ. ಸ್ವಾತಿ, ಮೇಲಿಂದ ಬಟ್ಟೆ ತಗೊಂಬಾ.
ಹಾಂ ಅಮ್ಮ.
ಸ್ವಾತಿ, ಶರತ್ ಕಾಲ್ ಮಾಡ್ತಾ ಇದ್ದಾನೆ, ಬಾಮ್ಮ. ಹೌದು ಹೌದು, ಆಯ್ತು ಆಯ್ತು, ಬಂದ್ಲು, ಕೊಡ್ತೇನೆ.
ಹಲೋ, ಅಮ್ಮ, ಪಕ್ಕದ ಮನೇಲಿ ಯಾರಾದರೂ ಬಂದಿದ್ದಾರಾ?
ಬಂದಿದ್ದಾರೆ, 2 ತಿಂಗಳಾಯ್ತು. ಅನಿತಾ ಅಂತ, ಯಾರೋ ಬ್ಯಾಂಕ್ನಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಾರೆ.
ಆದರೂ ಅಮ್ಮ, ಅವ್ರು ನೋಡೋಕೆ ಎಷ್ಟು ಚಂದ ಇದ್ದಾರಲ್ಲ.
ಏನು ಚಂದನೋ ಏನು ಸಿರಿನೋ, ಮಕ್ಕಳಿಲ್ಲ ಮರಿ ಇಲ್ಲ, ಯಾರಿಗ ಚಂದ ಸಿರಿ ಮಾಡ್ಕೋತಾಳೋ. ಮದುವೆ ಆಗಿದ್ದಾಳೆ, ಗಂಡ ಸತ್ತಿದ್ದಾನೆ, ಇರೋದು ನೋಡಿದ್ಯಾ ಹೇಗಿದ್ದಾಳೆ ಅಂತ.
ಆದರೂ ಅಮ್ಮ, ಅವ್ರ ಗಂಡನ ಕೊನೆ ಆಸೆ ಆಗಿರ್ಬೇಕಲ್ವಾ, ಅವ್ರು ತೀರ್ಕೊಂಡ್ಮೇಲೂ ಹೀಗೆ ರೆಡಿ ಆಗಬೇಕು ಅಂತ. ಇನ್ಫ್ಯಾಕ್ಟ್ ಅವ್ರ ವರ್ಡ್ಸ್ ಬೆಸ್ಟ್ ವೈಫ್. ಈಗಲೂ ಅವ್ರ ಗಂಡನ ಕೊನೆ ಆಸೆನ ನೆರವೇರಿಸ್ಕೊಂಡು ಹೊರಟಿದ್ದಾರೆ.
ಹಾಗಲಕಾಯಿ ಬೇಂಕಾಯಿ ಸಾಕ್ಷಿ ಅಂದಂಗೆ ಇಬ್ಬರು ಚಲೋ ಇದ್ದೀರ. ನೀನು ಗಂಡ ಇದ್ದರೂ ಇಲ್ದಿರೋ ಹಾಗೆ ತಿರುಗ್ತೀಯ. ಆಕಿನೋ ಗಂಡ ಸತ್ರು ಇರೋರಂಗೆ ತಿರುಗ್ತಾಳೆ. ಚಿಕ್ಕವರು ದೊಡ್ಡವರು ಎಲ್ಲರೂ ಒಂದೇ ಥರ ಇದ್ದೀರ. ನಿಮ್ಮ ಮನಸ್ಸಿಗೆ ಬಂದಾಗೆ ಮಾಡ್ಕೊಳ್ಳಿ. ಸಂಜೆ ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಬೇಕು. ಹಾಂ, ಹೀಗೆಲ್ಲ ಹೋಗಬೇಡ, ಈ ಸೀರೆನಾದರೂ ಉಟ್ಕೊಂಡು ಹೋಗು.
ಅಯ್ಯೋ ಬೇಡ ಮ್ಯಾಮ್.
ಇದು ಯಾವ ದೇವಸ್ಥಾನ?
ದುರ್ಗಾ ಪರಮೇಶ್ವರಿ ದೇವಸ್ಥಾನ.
ಹೌದಾ? ದೇವಿ ಯಾವ ಬಣ್ಣದ ಸೀರೆ ಹುಟ್ಟಿದ್ದಾಳೆ?
ಅದು ಅಮ್ಮ.
ಅಷ್ಟೇ, ಮುಗೀತು. ಈಗ ಹೇಗಿದೆ ನೋವು?
ಈಗ ಸರಿ ಹೋಯ್ತು.
ಮತ್ತೆ ಕುಳಿತಿದೆಯಾ? ಇಷ್ಟೊಂದು ನಾಜೂಕಾದ್ರೆ ಬ್ಯೂಟಿ ಪರಿಸ್ಥಿತಿ ಏನಾಗಬೇಕು?
ಮ್ಯಾಮ್, ಬೇರೆಯವ್ರ ಬಗ್ಗೆ ನಂಗೆ ಗೊತ್ತಿಲ್ಲ, ಆದರೆ ನನ್ನ ಪ್ರಕಾರ ಮಿಸ್ ಬ್ಯೂಟಿಫುಲ್ ಪರ್ಸನಾಲಿಟಿ ಅಂದರೆ ಅದು ನೀವೇ.
ನೋಡು, ಈ ಸಮಾಜದಲ್ಲಿ ನಾವು ಒಬ್ಬರು, ಆದರೆ ಈ ಸಮಾಜದಿಂದ ಬರೋ ಜಡ್ಜ್ಮೆಂಟ್ಸ್ ಲೆಕ್ಕಕ್ಕಿಲ್ಲ. ಸೊ ಯಾರನ್ನು ಖುಷಿಯಾಗಿರ್ತೀಯಾ? ಎಲ್ರನ್ನ ಅಥವಾ ನಿನ್ನನ್ನ? ಸರಿ, ನಂಗೆ ಕೆಲಸ ಇದೆ, ಬಾಯ್.
ಎಷ್ಟು ಸರಳವಾಗಿ ಅವ್ರು ಹೀಗೆ ರೆಡಿ ಆಗೋದು ಅವ್ರ ಖುಷಿಗೆ ಕಾರಣ ಅಂತ ಹೇಳಿದರು. ಬಹಳ ಜನ ತಮ್ಮ ಖುಷಿ ಕೆಲಸ ಮಾಡಿ ಬೇರೆಯವ್ರ ಹೆಸರು ಹೇಳಿದ್ದೇ ಜಾಸ್ತಿ. ಆದರೆ ಅನಿತಾ ಮ್ಯಾಮ್ ನನ್ನ ಗಂಡನ ಕೊನೆ ಆಸೆ ಅಂತ ಯಾಕೆ ಸುಳ್ಳು ಹೇಳಿಲ್ಲ? ತಮ್ಮನ್ನು ತಾವು ಈ ಸಮಾಜದಿಂದ ಯಾಕೆ ಸೇವ್ ಮಾಡ್ಕೊಳ್ಳಿಲ್ಲ?
ഹലോ ആ ദേവുട്ടിയാണല്ലോ. ആകാശ് ഇവിടെ ഉണ്ടല്ലോ. ഓ ഞാൻ കൊടുക്കാട്ടോ.
ഒന്ന് പോയി തരുവിടുന്നു. പോവാൻ പറഞ്ഞില്ലേ ഞാൻ എടുത്തു.
ഹലോ എനിക്കറിയൂല. അവൻ കുറേ ദിവസമായിട്ട് ഭയങ്കര ദേഷ്യമാണ്. ആരടുത്ത് സംസാരിക്കാൻ വേണ്ട. ഏട്ടൻ നേരിട്ട് ഇങ്ങോട്ട് വന്ന് സംസാരിച്ചേക്കൊണ്ടെടുത്ത്. എന്നാ വാ പോവാ.
ദിയ സാറാ
താങ്ക്സ്.
ഒട്ടും പ്രതീക്ഷിക്കാതെയാണ് ചില മനുഷ്യരുടെ ജീവിതത്തിൽ പല മാറ്റങ്ങളും സംഭവിക്കുന്നത്.
മിസ് ചെയ്യണ്ടല്ലേ? എത്ര അടിപൊളിയായിരുന്നു നമ്മുടെ ആ പഴയ കാലം. എല്ലാം നശിച്ചു, നീ നശിപ്പിച്ചു. കൂടുള്ള എല്ലാവരും നിന്നെ വെറുത്തു, നിന്റെ നശിച്ച ഡ്രഗ് യൂസ് കാരണം. എന്ന് വെച്ചെല്ലാം അവസാനിച്ചു എന്നല്ല. നിനക്ക് കിട്ടാൻ പോകുന്ന ഒരു ഗോൾഡൻ ഓപ്പർച്യൂണിറ്റിയാണ് ഈ വരുന്ന യൂണിവേഴ്സിറ്റി എക്സാം. ഇതിൽ നിനക്ക് നല്ല മാർക്ക് സ്കോർ ചെയ്യാൻ കഴിഞ്ഞാൽ നഷ്ടപ്പെട്ടതെല്ലാം തിരിച്ചു പിടിക്കാനുള്ള ഒരു അവസരമാണ്. You better don't miss this chance.
Examination result comes and the first rank goes to Noel Matthew. Mistakes happen, it's all human things. But being trapped in it and forget the reality is nothing lesser than having a life in hell. Sometimes all they need is someone to hold, someone to stand beside them, someone to understand and try to pull up them from the loophole. A helping hand.
ಈಗ ಬಂದ್ಯಾ? ಹೋ, ನೀ ಫ್ರೆಶ್ ಅಪ್ ಆಗಿ ಬಾ, ನಾನು ಟೀ ಮಾಡ್ತೇನೆ. ನೀವಿಬ್ರು ಚೆನ್ನಾಗಿದ್ದೀರ್ತಾನೆ?
ಹಾಂ, ಚೆನ್ನಾಗಿದ್ದೀವಿ.
ಶರತ್, ನೀವು ಇಬ್ರು ಚೆನ್ನಾಗಿದ್ದೀರಿ ತಾನೆ?
ಯಾಕಮ್ಮ ಹೀಗೆ ಕೇಳ್ತಾ ಇದೆಯಾ? ನಾನು, ನಮ್ಮ ಗಂಡ, ನಮ್ಮ ಅತ್ತೆ, ಮಾವ ಎಲ್ಲರೂ ಚೆನ್ನಾಗಿದ್ದೀವಿ.
ಮತ್ತೆ ಏನಿದು ಕಾಲೇಜ್ ಹುಡುಗಿ ಥರ ಇದೆಯಾ? ಮದುವೆ ಆದರೂ ಈ ಥರ ಇದೆಯಾ? ನೋಡಿದವ್ರು ಏನಂತಾರೆ? ಕೈಯಲ್ಲೊಂದು ಬಳೆ ಇಲ್ಲ, ಹಣೆ ಮೇಲೆ ಕುಂಕುಮ ಇಲ್ಲ, ಸರ ಇಲ್ಲ, ಈ ಥರ ಬಂದಿದ್ಯಾ ನೀನು. ನೋಡಿದ ಜನ ಏನಂತಾರೆ ಅಂತ ಇಲ್ಲ. ಸ್ವಾತಿ, ಮೇಲಿಂದ ಬಟ್ಟೆ ತಗೊಂಬ.
ಹಾಂ ಅಮ್ಮ.
ಸ್ವಾತಿ, ಶರತ್ ಕಾಲ್ ಮಾಡ್ತಾ ಇದ್ದಾನೆ, ಬಾಮ್ಮ. ಹೌದು ಹೌದು, ಆಯ್ತು ಆಯ್ತು, ಬಂದ್ಲು, ಕೊಡ್ತೇನೆ.
ಹಲೋ, ಅಮ್ಮ, ಪಕ್ಕದ ಮನೇಲಿ ಯಾರಾದರೂ ಬಂದಿದ್ದಾರಾ?
ಬಂದಿದ್ದಾರೆ, 2 ತಿಂಗಳಾಯ್ತು. ಅನಿತಾ ಅಂತ, ಯಾರೋ ಬ್ಯಾಂಕ್ನಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಾರೆ.
ಆದರೂ ಅಮ್ಮ, ಅವ್ರು ನೋಡೋಕೆ ಎಷ್ಟು ಚಂದ ಇದ್ದಾರಲ್ಲ.
ಏನು ಚಂದನೋ ಏನು ಸಿರಿನೋ, ಮಕ್ಕಳಿಲ್ಲ ಮರಿ ಇಲ್ಲ, ಯಾರಿಗ ಚಂದ ಸಿರಿ ಮಾಡ್ಕೋತಾಳೋ. ಮದುವೆ ಆಗಿದ್ದಾಳೆ, ಗಂಡ ಸತ್ತಿದ್ದಾನೆ, ಇರೋದು ನೋಡಿದ್ಯಾ ಹೇಗಿದ್ದಾಳೆ ಅಂತ.
ಆದರೂ ಅಮ್ಮ, ಅವ್ರ ಗಂಡನ ಕೊನೆ ಆಸೆ ಆಗಿರ್ಬೇಕಲ್ವಾ, ಅವ್ರು ತೀರ್ಕೊಂಡ್ಮೇಲೂ ಹೀಗೆ ರೆಡಿ ಆಗಬೇಕು ಅಂತ. ಇನ್ಫ್ಯಾಕ್ಟ್ ಅವ್ರ ವರ್ಡ್ಸ್ ಬೆಸ್ಟ್ ವೈಫ್. ಈಗಲೂ ಅವ್ರ ಗಂಡನ ಕೊನೆ ಆಸೆನ ನೆರವೇರಿಸ್ಕೊಂಡು ಹೊರಟಿದ್ದಾರೆ.
ಹಾಗಲಕಾಯಿ ಬೇವಿನಕಾಯಿ ಸಾಕ್ಷಿ ಅಂದಾಗೆ ಇಬ್ಬರು ಚಲೋ ಇದ್ದೀರ. ನೀನು ಗಂಡ ಇದ್ದರೂ ಇಲ್ದಿರೋ ಹಾಗೆ ತಿರುಗ್ತೀಯ. ಆಕಿನೋ ಗಂಡ ಸತ್ರು ಇರೋರಂಗೆ ತಿರುಗ್ತಾಳೆ. ಚಿಕ್ಕವರು ದೊಡ್ಡವರು ಎಲ್ಲರೂ ಒಂದೇ ಥರ ಇದ್ದೀರ. ನಿಮ್ಮ ಮನಸ್ಸಿಗೆ ಬಂದಾಗೆ ಮಾಡ್ಕೊಳ್ಳಿ. ಸಂಜೆ ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಬೇಕು. ಹಾಂ, ಹೀಗೆಲ್ಲ ಹೋಗಬೇಡ, ಈ ಸೀರೆನಾದರೂ ಉಟ್ಕೊಂಡು ಹೋಗು.
ಅಯ್ಯೋ ಬೇಡ ಮ್ಯಾಮ್.
ಇದು ಯಾವ ದೇವಸ್ಥಾನ?
ದುರ್ಗಾ ಪರಮೇಶ್ವರಿ ದೇವಸ್ಥಾನ.
ಹೌದಾ? ದೇವಿ ಯಾವ ಬಣ್ಣದ ಸೀರೆ ಹುಟ್ಟಿದ್ದಾಳೆ?
ಅದು ಅಮ್ಮ.
ಅಷ್ಟೇ, ಮುಗೀತು. ಈಗ ಹೇಗಿದೆ ನೋವು?
ಈಗ ಸರಿ ಹೋಯ್ತು.
ಮತ್ತೆ ಕುಳಿತಿದೆಯಾ? ಇಷ್ಟೊಂದು ನಾಜೂಕಾದ್ರೆ ಬ್ಯೂಟಿ ಪರಿಸ್ಥಿತಿ ಏನಾಗಬೇಕು?
ಮ್ಯಾಮ್, ಬೇರೆಯವ್ರ ಬಗ್ಗೆ ನಂಗೆ ಗೊತ್ತಿಲ್ಲ, ಆದರೆ ನನ್ನ ಪ್ರಕಾರ ಮಿಸ್ ಬ್ಯೂಟಿಫುಲ್ ಪರ್ಸನಾಲಿಟಿ ಅಂದರೆ ಅದು ನೀವೇ.
ನೋಡು, ಈ ಸಮಾಜದಲ್ಲಿ ನಾವು ಒಬ್ರು, ಆದರೆ ಈ ಸಮಾಜದಿಂದ ಬರೋ ಜಡ್ಜ್ಮೆಂಟ್ಸ್ ಲೆಕ್ಕಕ್ಕಿಲ್ಲ. ಸೊ ಯಾರನ್ನು ಖುಷಿಯಾಗಿರ್ತೀಯಾ? ಎಲ್ರನ್ನ ಅಥವಾ ನಿನ್ನನ್ನ? ಸರಿ, ನಂಗೆ ಕೆಲಸ ಇದೆ, ಬಾಯ್.
ಎಷ್ಟು ಸರಳವಾಗಿ ಅವ್ರು ಹೀಗೆ ರೆಡಿ ಆಗೋದು ಅವ್ರ ಖುಷಿಗೆ ಕಾರಣ ಅಂತ ಹೇಳಿದ್ರು. ಬಹಳ ಜನ ತಮ್ಮ ಖುಷಿ ಕೆಲಸ ಮಾಡಿ ಬೇರೆಯವ್ರ ಹೆಸರು ಹೇಳಿದ್ದೇ ಜಾಸ್ತಿ. ಆದರೆ ಅನಿತಾ ಮ್ಯಾಮ್ ನನ್ನ ಗಂಡನ ಕೊನೆ ಆಸೆ ಅಂತ ಯಾಕೆ ಸುಳ್ಳು ಹೇಳಿಲ್ಲ? ತಮ್ಮನ್ನು ತಾವು ಈ ಸಮಾಜದಿಂದ ಯಾಕೆ ಸೇವ್ ಮಾಡ್ಕೊಳ್ಳಿಲ್ಲ?
ഹലോ ആ ദേവുട്ടിയാണല്ലോ. ആകാശ് ഇവിടെ ഉണ്ടല്ലോ. ഓ ഞാൻ കൊടുക്കാട്ടോ.
ഒന്ന് പോയി തരുവിടുന്നു. പോവാൻ പറഞ്ഞില്ലേ ഞാൻ എടുത്തു.
ഹലോ എനിക്കറിയൂല. അവൻ കുറേ ദിവസമായിട്ട് ഭയങ്കര ദേഷ്യമാണ്. ആരടുത്ത് സംസാരിക്കാൻ വേണ്ട. ഏട്ടൻ നേരിട്ട് ഇങ്ങോട്ട് വന്ന് സംസാരിച്ചേക്കൊണ്ടെടുത്ത്.
എന്നാ വാ പോവാ.
Dia.
Sarah?
Thanks.
ഒട്ടും പ്രതീക്ഷിക്കാതെയാണ് ചില മനുഷ്യരുടെ ജീവിതത്തിൽ പല മാറ്റങ്ങളും സംഭവിക്കുന്നത്.
മിസ് ചെയ്യണ്ടല്ലേ? എത്ര അടിപൊളിയായിരുന്നു നമ്മുടെ ആ പഴയ കാലം. എല്ലാം നശിച്ചു, നീ നശിപ്പിച്ചു. കൂടുള്ള എല്ലാവരും നിന്നെ വെറുത്തു, നിന്റെ നശിച്ച ഡ്രഗ് യൂസ് കാരണം. എന്ന് വെച്ചെല്ലാം അവസാനിച്ചു എന്നല്ല. നിനക്ക് കിട്ടാൻ പോകുന്ന ഒരു ഗോൾഡൻ ഓപ്പർച്യൂണിറ്റിയാണ് ഈ വരുന്ന യൂണിവേഴ്സിറ്റി എക്സാം. ഇതിൽ നിനക്ക് നല്ല മാർക്ക് സ്കോർ ചെയ്യാൻ കഴിഞ്ഞാൽ നഷ്ടപ്പെട്ടതെല്ലാം തിരിച്ചു പിടിക്കാനുള്ള ഒരു അവസരമാണ്. You better don't miss this chance.
Examination result comes and the first rank goes to Noel Matthew. Mistakes happen, it's all human things. But being trapped in it and forget the reality is nothing lesser than having a life in hell. Sometimes all they need is someone to hold, someone to stand beside them, someone to understand and try to pull up them from the loophole. A helping hand.
ಈಗ ಬಂದ್ಯಾ? ಹೋ, ನೀ ಫ್ರೆಶ್ ಅಪ್ ಆಗಿ ಬಾ, ನಾನು ಟೀ ಮಾಡ್ತೇನೆ. ನೀವಿಬ್ರು ಚೆನ್ನಾಗಿದ್ದಿರ್ತಾನೆ?
ಹಾಂ, ಚೆನ್ನಾಗಿದ್ದೀವಿ.
ಶರತ್, ನೀವು ಇಬ್ರು ಚೆನ್ನಾಗಿದ್ದೀರಿ ತಾನೆ?
ಯಾಕಮ್ಮ ಹೀಗೆ ಕೇಳ್ತಾ ಇದೆಯಾ? ನಾನು, ನಮ್ಮ ಗಂಡ, ನಮ್ಮ ಅತ್ತೆ, ಮಾವ ಎಲ್ಲರೂ ಚೆನ್ನಾಗಿದ್ದೀವಿ.
ಮತ್ತೆ ಏನಿದು ಕಾಲೇಜ್ ಹುಡುಗಿ ಥರ ಇದೆಯಾ? ಮದುವೆ ಆದರೂ ಈ ಥರ ಇದೆಯಾ? ನೋಡಿದವ್ರು ಏನಂತಾರೆ? ಕೈಯಲ್ಲೊಂದು ಬಳೆ ಇಲ್ಲ, ಹಣೆ ಮೇಲೆ ಕುಂಕುಮ ಇಲ್ಲ, ಸರ ಇಲ್ಲ, ಈ ಥರ ಬಂದಿದ್ಯಾ ನೀನು. ನೋಡಿದ ಜನ ಏನಂತಾರೆ ಅಂತ ಇಲ್ಲ. ಸ್ವಾತಿ, ಮೇಲಿಂದ ಬಟ್ಟೆ ತಗೊಂಬ.
ಹಾಂ ಅಮ್ಮ.
ಸ್ವಾತಿ, ಶರತ್ ಕಾಲ್ ಮಾಡ್ತಾ ಇದ್ದಾನೆ, ಬಾಮ್ಮ. ಹೌದು ಹೌದು, ಆಯ್ತು ಆಯ್ತು, ಬಂದ್ಲು, ಕೊಡ್ತೇನೆ.
ಹಲೋ, ಅಮ್ಮ, ಪಕ್ಕದ ಮನೇಲಿ ಯಾರಾದರೂ ಬಂದಿದ್ದಾರಾ?
ಬಂದಿದ್ದಾರೆ, 2 ತಿಂಗಳಾಯ್ತು. ಅನಿತಾ ಅಂತ, ಯಾರೋ ಬ್ಯಾಂಕ್ನಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಾರೆ.
ಆದರೂ ಅಮ್ಮ, ಅವ್ರು ನೋಡೋಕೆ ಎಷ್ಟು ಚಂದ ಇದ್ದಾರಲ್ಲ.
ಏನು ಚಂದನೋ ಏನು ಸಿರಿನೋ, ಮಕ್ಕಳಿಲ್ಲ ಮರಿ ಇಲ್ಲ, ಯಾರಿಗ ಚಂದ ಸಿರಿ ಮಾಡ್ಕೋತಾಳೋ. ಮದುವೆ ಆಗಿದ್ದಾಳೆ, ಗಂಡ ಸತ್ತಿದ್ದಾನೆ, ಇರೋದು ನೋಡಿದ್ಯಾ ಹೇಗಿದ್ದಾಳೆ ಅಂತ.
ಆದರೂ ಅಮ್ಮ, ಅವ್ರ ಗಂಡನ ಕೊನೆ ಆಸೆ ಆಗಿರ್ಬೇಕಲ್ವಾ, ಅವ್ರು ತೀರ್ಕೊಂಡ್ಮೇಲೂ ಹೀಗೆ ರೆಡಿ ಆಗಬೇಕು ಅಂತ. ಇನ್ಫ್ಯಾಕ್ಟ್ ಅವ್ರ ವರ್ಡ್ಸ್ ಬೆಸ್ಟ್ ವೈಫ್. ಈಗಲೂ ಅವ್ರ ಗಂಡನ ಕೊನೆ ಆಸೆನ ನೆರವೇರಿಸ್ಕೊಂಡು ಹೊರಟಿದ್ದಾರೆ.
ಹಾಗಲಕಾಯಿ ಬೇಂಕಾಯಿ ಸಾಕ್ಷಿ ಅಂದಂಗೆ ಇಬ್ಬರು ಚಲೋ ಇದ್ದೀರ. ನೀನು ಗಂಡ ಇದ್ದರೂ ಇಲ್ದಿರೋ ಹಾಗೆ ತಿರುಗ್ತೀಯ. ಆಕಿನೋ ಗಂಡ ಸತ್ರು ಇರೋರಂಗೆ ತಿರುಗ್ತಾಳೆ. ಚಿಕ್ಕವರು ದೊಡ್ಡವರು ಎಲ್ಲರೂ ಒಂದೇ ಥರ ಇದ್ದೀರ. ನಿಮ್ಮ ಮನಸ್ಸಿಗೆ ಬಂದಾಗೆ ಮಾಡ್ಕೊಳ್ಳಿ. ಸಂಜೆ ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋಗಬೇಕು. ಹಾಂ, ಹೀಗೆಲ್ಲ ಹೋಗಬೇಡ, ಈ ಸೀರೆನಾದರೂ ಉಟ್ಕೊಂಡು ಹೋಗು.
ಅಯ್ಯೋ ಬೇಡ ಮ್ಯಾಮ್.
ಇದು ಯಾವ ದೇವಸ್ಥಾನ?
ದುರ್ಗಾ ಪರಮೇಶ್ವರಿ ದೇವಸ್ಥಾನ.
ಹೌದಾ? ದೇವಿ ಯಾವ ಬಣ್ಣದ ಸೀರೆ ಉಟ್ಟಿದ್ದಾಳೆ?
ಅದು ಅಮ್ಮ.
ಅಷ್ಟೇ, ಮುಗೀತು. ಈಗ ಹೇಗಿದೆ ನೋವು?
ಈಗ ಸರಿ ಹೋಯ್ತು.
ಮತ್ತೆ ಕುಳಿತಿದೆಯಾ? ಇಷ್ಟೊಂದು ನಾಜೂಕಾದ್ರೆ ಬ್ಯೂಟಿ ಪರಿಸ್ಥಿತಿ ಏನಾಗಬೇಕು?
ಮ್ಯಾಮ್, ಬೇರೆಯವ್ರ ಬಗ್ಗೆ ನಂಗೆ ಗೊತ್ತಿಲ್ಲ, ಆದರೆ ನನ್ನ ಪ್ರಕಾರ ಮಿಸ್ ಬ್ಯೂಟಿಫುಲ್ ಪರ್ಸನಾಲಿಟಿ ಅಂದರೆ ಅದು ನೀವೇ.
ನೋಡು, ಈ ಸಮಾಜದಲ್ಲಿ ನಾವು ಒಬ್ರು, ಆದರೆ ಈ ಸಮಾಜದಿಂದ ಬರೋ ಜಡ್ಜ್ಮೆಂಟ್ಸ್ ಲೆಕ್ಕಕ್ಕಿಲ್ಲ. ಸೊ ಯಾರನ್ನು ಖುಷಿಯಾಗಿರ್ತೀಯಾ? ಎಲ್ರನ್ನ ಅಥವಾ ನಿನ್ನನ್ನ? ಸರಿ, ನಂಗೆ ಕೆಲಸ ಇದೆ, ಬಾಯ್.
ಎಷ್ಟು ಸರಳವಾಗಿ ಅವ್ರು ಹೀಗೆ ರೆಡಿ ಆಗೋದು ಅವ್ರ ಖುಷಿಗೆ ಕಾರಣ ಅಂತ ಹೇಳಿದ್ರು. ಬಹಳ ಜನ ತಮ್ಮ ಖುಷಿ ಕೆಲಸ ಮಾಡಿ ಬೇರೆಯವ್ರ ಹೆಸರು ಹೇಳಿದ್ದೇ ಜಾಸ್ತಿ. ಆದರೆ ಅನಿತಾ ಮ್ಯಾಮ್ ನನ್ನ ಗಂಡನ ಕೊನೆ ಆಸೆ ಅಂತ ಯಾಕೆ ಸುಳ್ಳು ಹೇಳಿಲ್ಲ? ತಮ್ಮಂತಾವು ಈ ಸಮಾಜದಿಂದ ಯಾಕೆ ಸೇವ್ ಮಾಡ್ಕೊಳ್ಳಿಲ್ಲ?
ഞാൻ കൊടുക്കാട്ടോ.
ഒന്ന് പോയി തരുവായിരുന്നു. പോവാൻ പറഞ്ഞില്ലേ ഞാൻ എടുത്തു.
ഹലോ,
എനിക്കറിയൂല. അവൻ കുറേ ദിവസമായിട്ട് ഭയങ്കര ദേഷ്യമാണ്. ആരടുത്ത് സംസാരിക്കാൻ വേണ്ട. ഏട്ടൻ നേരിട്ട് ഇങ്ങോട്ട് വന്ന് സംസാരിച്ചേക്കൊണ്ടിരുന്നത്.
എന്നാ വാ പോവാ.
ദിയ,
സാറാ,
താങ്ക്സ്.
ഒട്ടും പ്രതീക്ഷിക്കാതെയാണ് ചില മനുഷ്യരുടെ ജീവിതത്തിൽ പല മാറ്റങ്ങളും സംഭവിക്കുന്നത്.
മിസ് ചെയ്യണ്ടല്ലേ? എത്ര അടിപൊളിയായിരുന്നു നമ്മുടെ ആ പഴയ കാലം. എല്ലാം നശിച്ചു, നീ നശിപ്പിച്ചു. കൂടുള്ള എല്ലാവരും നിന്നെ വെറുത്തു, നിന്റെ ഈ നശിച്ച ഡ്രഗ് യൂസ് കാരണം. എന്ന് വെച്ചെല്ലാം അവസാനിച്ചു എന്നല്ല. നിനക്ക് കിട്ടാൻ പോകുന്ന ഒരു ഗോൾഡൻ ഓപ്പർച്യൂണിറ്റിയാണ് ഈ വരുന്ന യൂണിവേഴ്സിറ്റി എക്സാം. ഇതിൽ നിനക്ക് നല്ല മാർക്ക് സ്കോർ ചെയ്യാൻ കഴിഞ്ഞാൽ നഷ്ടപ്പെട്ടതെല്ലാം തിരിച്ചു പിടിക്കാനുള്ള ഒരു അവസരമാണ്. You better don't miss this chance.
Finally, the university examination result comes and the first rank goes to Noel Matthew. Mistakes happen, it's all human things. But being trapped in it and forget the reality is nothing lesser than having a life in hell. Sometimes all they need is someone to hold, someone to stand beside them, someone to understand and try to pull up them from the loophole. A helping hand.
ಈಗ ಬಂದ್ಯಾ? ಹೋ
one team. So budding psychologists will be from 2 to 3. If you are interested, you can participate in that event also. Thank you.
Next round.
Are you ready for this game?
Listen here.
So instructions will be like, only one person from a team participates in this round. You get 1 point for observation and 5 minutes to write. Observe very carefully, minute details carry marks. Make sure your writing is clear and readable. Choose the participant wisely as the other member will have to attend a different round simultaneously. We'll have a set of equipments related to crime kept there. You have to come, you have to observe everything, and you have to write whatever items you have seen there. If you write minute details, you will get half marks more. If you write only thing observed, you will get 1 mark. Phones ಮತ್ತೆ pens ಎಲ್ಲ ಇಲ್ಲೇ ಇಟ್ಟು ಬರಬೇಕು. You are not supposed to carry your phones and your pens. So team 1 to 6, each one get up. ಈ ಕಡೆ ಬರೋದು.
To extend a warm and gracious welcome to this esteemed gathering, I
respected dignitaries, esteemed faculty, delegates, participants, and well-wishers present here. Challenges. We are deeply privileged to be graced by the presence of leadership that guides and inspires the SDM, education society, and academic community. So we begin and extending our profound gratitude to the and reverence to the figure whose vision shapes our path. It is our immense
Om Shri Manjunathaya Namaha. A warm and respectful good evening to all the dignitaries present on the dais and off the dais, faculty members, our esteemed resource persons, coordinators, participants, and dear students. I am Priyanka from 2nd MSc Psychology. Before we begin, let us remember, every ending is just a gentle pause before a new beginning. And when the journey has enriched our mind and strengthened our purpose, the end becomes a celebration. Today, we gather here to mark the conclusion of a remarkable academic event, the 2 days national level conference on promoting human rights in mental health care, approaches, challenges and opportunities, and also the end of the Psychovision Fest, organized by the Department of Postgraduate Studies and Research in Psychology. Over the past 2 days, we have shared knowledge, insights, experiences, and meaningful discussions that will surely remain with us as we continue our journey in the field of psychology. And now, we come together for the valedictory session, which marks the formal closing of this enriching event. This national conference was graced by an enriching diversity of participants representing institutions and professions from across the country and beyond. We are honored to have welcomed delegates from various regions of India, Karnataka, Kerala, Tamil Nadu and Punjab, each contributing unique perspectives. We are equally privileged to have hosted international participation from Cambodia. The presence of such a wide spectrum of scholars, practitioners and students elevates this conference into a truly collaborative and cross-cultural intellectual platform. The conference was also followed by our vibrant and engaging Psychovision Fest that brought together a series of unique, engaging and truly amazing competitions. Now, to extend a warm and gracious welcome to this esteemed gathering, I now invite Ms. Alfia from 2nd MSc Psychology to deliver the welcome address.
Good evening to one and all present here. I am Alfia from 2nd MSc Psychology. With immense pleasure and heartfelt gratitude, I warmly welcome you all to the valedictory session of this wonderful program. Over the past days, we have shared meaningful discussions, inspiring ideas and enriching experiences. Today, as we come together to mark the conclusion of this journey, we also celebrate the effort, dedication and enthusiasm that each one of you brought to this event. It is my honor to extend a heartfelt welcome to each one of you. I am pleased to welcome our esteemed chief guest, Dr. Shanmughi, consultant psychologist. I welcome you, ma'am. I also welcome P. Ganesh Nayak, register evaluator. Welcome you, sir. And also, respected faculty members, invited guests, and all the offline and online participants who have joined us for this concluding sermon. Your presence here had grace and significance to this occasion, and we are truly delighted to have you with us. Also, I respectfully welcome Dr. Mahesh Babu, sir, co-convener, and Ms. Ashwini H, organizing secretary, and Ms. Kirtana, the vice president. And I also take this moment to warmly welcome all students, coordinators, volunteers, and well-wishers who have contributed to this program and are here to witness its formal conclusion. Once again, I sincerely extend my respectful welcome to all.
Thank you, Alfia. I extend a warm welcome to you as well. Moving on, we now have the bookmark handover ceremony, a gesture that symbolizes harmony, knowledge, and the spirit of this 2-day national conference. To begin, I kindly invite Mr. Nishant, Peace Association Secretary from 2nd MSc Psychology, to ceremoniously hand over the bookmark to our chief guest of the event, Dr. Shanmughi. Next, I invite Ms. Ashura Faiza, Joint Secretary of the first year MSc Psychology, to hand over the bookmark to Mr. Ganesh Nayak, the President of today's event. Following this, I request Ms. Shreya P, Class Representative of first year MSc Psychology, to present the bookmark to Dr. Mahesh Babu. Azrina, Treasurer of the Peace Association, to kindly present the bookmark to the Organizing Secretary of the event, Ms. Ashwini H. And lastly, I invite Ms. Impu, class representative of second year MSc Psychology, to hand over the bookmark to Ms. Keertana, President of the Peace Association and the student coordinator of the 2 days national conference. Thank you everyone. To present the deep briefing report of this 2-day national conference, I invite Ms. Keertana, student coordinator and president of the Peace Association.
Good evening to one and all present here. I, Keertana A, President of Peace Association. It's my privilege to present the debriefing report of the 2-day national conference on promoting human rights in mental health care, approaches, opportunities and challenges, organized by the Department of Postgraduate Studies and Research in Psychology, SDM College, UJIRE. The conference was inaugurated on 11 December 2025 at Seminar Hall 2, SDM PG Center. This event marked not only an important academic gathering but also a significant moment for the Department of Psychology as it celebrates 26 years of excellence. Our institution, guided by the leadership of Reverend Dr. D. Dharmadikari of DHARMASTHALA, continues to uphold its reputation for academic excellence and value-based education. With an A++ NAAC Re-accreditation, SDM College UJIRE stands as strong in its mission of holistic education and community engagement. This 2-day conference was envisioned to strengthen our right-based, inclusive and equitable framework in mental health care, bringing together researchers, practitioners and students to share insights and challenges. The inaugural session began at 9:30 a.m. with a soulful prayer by Purvi and team, followed by a warm welcome address by Dr. Mahesh Babu N. The conference was formally inaugurated by Dr. Satish Chandra S., Secretary, STME Society UJIRE, who also released the Silver Jubilee Compendium and delivered the inaugural address, emphasizing the importance of integrating human rights perspectives in mental health practices. Dr. Vandana Jain, Head of the Department of Psychology, SDM College UJIRE, provided a brief on the book release, followed by Ms. Sindhu B. introduced the department annual magazine, which was released by Dr. Soumya BP, Dean of PG Studies, SDM PG Center, UJIRE. A moment of honor followed as a Professor Viswanatha P., Principal of SDM College UJIRE, felicitated Dr. Taranatha Shetty, Principal, SDM Law College, Mangalore, delivered the chief guest address focusing on the legal and ethical dimensions of mental health care. In his presidential address, Professor Viswanatha P. highlighted the need for a rights-based approach in modern mental health system. The session concluded with a heartfelt vote of thanks by Ms. Ashwini H. and smooth comparing by Ms. Smita N. and Ms. Tasneem Jaiman, MSc Psychology students. By 11 a.m., the keynote address by Dr. Taranatha Shetty commenced, setting the foundation by highlighting the legal perspectives of human rights in mental health. This was followed by the first technical session led by Professor Sois John, who provided an in-depth understanding of promoting human rights in mental health services, drawing from the NASW Code of Ethics, UNCRPD principles, and significant historical moments in Indian psychiatry. The technical session offered a rich academic insights and meaningful discourse throughout the conference. In the afternoon, by 2 p.m., the paper presentations commenced in both offline and online modes, marking an engaging start to the academic activities. The conference witnessed an enthusiastic academic response with a total registration of 222 participants, including 43 online and 26 offline paper presentations. In addition, 46 participants joined online and 76 attended offline, reflecting a strong presence from diverse institutions. We had enthusiastic participation from delegates across Kerala, Karnataka, Tamil Nadu and Punjab, along with an international participant from Cambodia, adding rich diversity and depth to the scholarly discussion. We express our sincere gratitude to the scientific chairperson and co-chairperson who led each sessions with dedication and excellence. The online sessions were coordinated by Dr. Madhushri S. and Dr. Ashwini
K for the first session, followed by Dr. Rakesh T.S. and Dr. Brinda Muniappa for the second session, and Dr. Yuvraj U along with Dr. Soumya Shri for the third session. The offline sessions in Seminar Hall 2 was led by Dr. Kaveshri KB and Dr. Vandana Jain, where the session in CR11 was overseen by Dr. Sudhir KB and Dr. Ashwini Shetty, and the session CR12 was led by Dr. Deepa Rastina and Dr. Akshata K. We deeply appreciate their leadership and their commitment and the seamless coordination which ensured the smooth conduct of the scientific session and enriched the overall academic experience of the conference. Adding to the academic vibrancy, two major events, Inquisitive Minds and Synced Up, were conducted from 2 p.m. to 5 p.m., providing an interactive platform for the students to showcase their knowledge and talent. On the second day of the conference, the proceedings commenced with a technical session at 10 a.m. led by Dr. Shanmuki, consultant clinical psychologist from Hyderabad. She delivered an insightful session on implications and challenges of the Mental Health Care Act 2017 on clinical practice. Her presentation offered a deep understanding of how the Act influences therapeutic process, clinical responsibilities, and ethical considerations in mental health care. Following the technical session at 11:30 a.m., a series of vibrant and engaging events began simultaneously across various classrooms, such as Chakraviva, Cinefesta, Reels Making, Mind Palette, and Budding Psychologists were held. Each event offered students a platform to express their skills, explore their interests, and engage in healthy competition. The lively participation and diverse activities added a dynamic spirit to the conference, creating an enriching and memorable experience for all involved. The fest showcased talent, teamwork, creativity, and critical thinking, reflecting the vibrant spirit of psychology students. Overall, this 2 days, this conference created a space for meaningful dialogue on the pressing need for rights-based mental health care in India. The insightful sessions, enthusiastic participation, and the creative energies of Psychovision Fest have together made this event a truly memorable success. As we conclude, we move forward with a strengthened commitment to fostering dignity, equality, autonomy, and a compassionate approach to mental health care. Every ending is a new beginning, and every gathering lives us wiser than before. Thank you.
Comprehensive report, Kirtana. We shall now proceed to the opinion sharing segment. I request participants who wish to offer their feedback or reflections to kindly step forward and share their views. You are welcome to share your reflections, learning experiences, or memorable moments from the conference.
Good afternoon, everyone. So first ನಾವು ತುಂಬ ಅನ್ಎಕ್ಸ್ಪೆಕ್ಟೆಡ್ ಆಗಿ ಬಂದ್ವಿ ಇಲ್ಲಿಗೆ. ಸೊ ತುಂಬ ಒಳ್ಳೆ ಒಂದು ಫೆಸ್ಟ್, ಒಂದು ಒಳ್ಳೆ ಪ್ರೋಗ್ರಾಮ್, ಒಂದು ಒಳ್ಳೆ ಕಾನ್ಫರೆನ್ಸ್, ಸೈಕೋವಿಷನ್ 2025-26.
ಇಲ್ಲಿ ಬಂದು ನಮಗೆ ಪ್ಯಾನಲ್ ಮೆಂಬರ್ಸ್ ಆ್ಯಕ್ಚುಲಿ ತುಂಬ ರಿಸೋರ್ಸಸ್ ಇತ್ತು ನಮ್ಮ ಪೇಪರ್ಗೆ ನಮಗೆ ಪ್ರೆಸೆಂಟೆಡ್. ಸೊ ಅದಕ್ಕೋಸ್ಕರ ಥ್ಯಾಂಕ್ ಯು ಫಾರ್ ದ ಪ್ಯಾನಲ್ ಮೆಂಬರ್ಸ್ ಆ್ಯಂಡ್ ಥ್ಯಾಂಕ್ ಯು SDM ಫಾರ್ ಗಿವಿಂಗ್ ದಿಸ್ ಆಪರ್ಚುನಿಟಿ ಆ್ಯಂಡ್ ಥ್ಯಾಂಕ್ ಯು ಫಾರ್ Reva University for our college to giving this opportunity for us. I would congratulate all the committee members. It was a great time that I had here because everything was well organized, I would say, and the hostility which we received in hostel, it was also good. So thank and congratulate all the members. Thank you so much.
ಎಲ್ರಿಗೂ ನಮಸ್ತೆ. ನನ್ನ ಹೆಸರು ಅಕ್ಷಿತಾ. ನಾನು ಅಂಬಿಕಾ ಡಿಗ್ರಿ ಕಾಲೇಜ್ ಪುತ್ತೂರಿಂದ ಬಂದಿದ್ದೇನೆ. ನಾನು ನಿಜವಾಗಿ ಇಲ್ಲಿ ಕಂಡಿರುವಂತಹ 4 ವಿಷಯಗಳಂತ ಹೇಳಿದರೆ ಸೇವೆ, ಸಂಸ್ಕೃತಿ, ಹೊಸ ಅನುಭವ, ಅದರ ಜೊತೆಗೆ ಭ್ರಾತೃತ್ವ. ಸೇವೆ ಸಂಸ್ಕೃತಿ ಅಂತ ಬಂದಾಗ ಎಂಟ್ರೆನ್ಸಲ್ಲೇ ಪೂಕಳಂನಲ್ಲಿ ಸೈಕಾಲಜಿ ಸಿಂಬಲ್ ಹಾಕಿ ಅದೊಂದು ನಮಗೆ ಬರುವಾಗಲೇ ಒಂದು ಒಳ್ಳೆ ಅಟ್ರಾಕ್ಟಿವ್ ಆಗಿ ಕಂಡಿತು. ಸೆಕೆಂಡ್ ಒನ್ ಸೇವೆ ಅನ್ನೋ ವಿಷಯನ ತೆಗೆದಾಗ ನಾನು 8:45 ಈ ಕಾಲೇಜಿಗೆ ಬಂದಿದ್ದೆ. ಆವಾಗ ಇಲ್ಲೆಲ್ಲ ಅರೇಂಜ್ ಮಾಡ್ತಿದ್ರು, ಬಟ್ ಯಾವುದೋ ಒಂದು ಬೇರೆ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಅವರು ಕೂಡ ನನಗೆ ಇಲ್ಲಿ ಸೆಮಿನಾರ್ ಹಾಲ್ ಇಲ್ಲಿ ಇದೆ, ಹೀಗೆ ಹೋಗಿ ಅಂತ ಹೇಳಿ ಒಂದು ನಮಗೆ ಹೇಳಿದ್ರು. ಇದು ನಿಜವಾಗಿ ಒಂದು ಕಾಲೇಜಲ್ಲಿರುವಂತಹ ಯೂನಿಟಿ ಆಗಿರ್ಬೋದು. ಇದು ಇಲ್ಲಿ ನಾನು ಸೇವೆಯ ರೂಪದಲ್ಲಿ ಕಾಣ್ತೀನಿ. ಅದರ ಜೊತೆಗೆ ನಮಗೆ ಏನೇ ಡೌಟ್ಸ್ ಇರ್ಬೋದು ಅಥವಾ ಏನೇ ವಿಷಯ ಹೇಳಿದ್ರು ಕೂಡ ಓಕೆ ನೀವು ಹೀಗೆ ಮಾಡಿ ಅಲ್ಲಿ ಉಂಟು ಪ್ರತಿಯೊಂದನ್ನು ಕೂಡ ಅಷ್ಟೊಂದು ಪೊಲೈಟ್ ಆಗಿ ನಮಗೆ ಫ್ರೆಂಡ್ಲಿ ಆಗಿ ಹೇಳಿದ್ದಾರೆ. ಇನ್ನು ಥರ್ಡ್ ಭ್ರಾತೃತ್ವ. ನಾನು ಪಾರ್ಟಿಸಿಪೇಟ್ ಮಾಡಿರೋದು ಚಕ್ರವ್ಯೂಹ. ಇದು ನಿಜವಾಗಿ ನಾನು ಪಾರ್ಟಿಸಿಪೇಟ್ ಮಾಡಿದ್ದು ಯಾಕಂತ ಹೇಳಿದ್ರೆ ಈ ಹೆಸರಿಗೋಸ್ಕರ ನಾನು ಪಾರ್ಟಿಸಿಪೇಟ್ ಮಾಡಿದ್ದು. ಈ ಚಕ್ರವ್ಯೂಹದಲ್ಲಿ ಏನಿರ್ತದೆ, ಹೀಗೆ ನಾವು ಕೂಡ ಅಭಿಮನ್ಯನಾಗಿ ಹೋಗ್ತೇವಾ ಅನ್ನೋದು ಹೊಸ ಅನುಭವಕ್ಕೆ ನಾನು ಬಂದೆ. ನಿಜವಾಗಿಯೂ ಇದು ಚಕ್ರವ್ಯೂಹ ಅಂತ ನನಗೆ ಅನಿಸ್ತುಂಟು. ಈ ಚಕ್ರವ್ಯೂಹದಲ್ಲಿ ನಾನು ಹೊಸ ಅನುಭವದ ರೀತಿಯಲ್ಲಿ ಹೇಳ್ಬೋದು. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ನನಗೆ ನಿಜವಾಗಿ ನಾನು ಸೈಕಾಲಜಿ ಫೆಸ್ಟ್ ಅಂದರೆ ಸೈಕೋ ವಿಷನ್ ಫೆಸ್ಟಿಗೆ ಬಂದದ್ದು ನನ್ನ ಫಸ್ಟ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಆ್ಯಂಡ್ ಸೈಕಾಲಜಿ ಫೆಸ್ಟಿಗೆ ಬಂದದ್ದು ನನ್ನ ಫಸ್ಟ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್. ಹಾಗಿರುವಾಗ ಈ ಒಂದು ಚಕ್ರವ್ಯೂಹದಲ್ಲಿ ಆದಂತಹ ಏನೆಲ್ಲ ವಿಷಯಗಳುಂಟು, ಅದನ್ನು ನಾವು ಹೇಗೆ ಮಾಡಬೇಕು, ಮತ್ತೆ ನಮ್ಮ IQ ಟೆಸ್ಟ್ ಹೇಗುಂಟು, ಇದನ್ನೆಲ್ಲ ಈ ಒಂದು ಚಕ್ರವ್ಯೂಹ ಆಕ್ಟಿವಿಟಿಯಲ್ಲಿ ನಾನು ಕಂಡಿದ್ದೇನೆ. ಅದಕ್ಕಿಂತಲೂ ನಾನು ಇನ್ನೊಂದು ವಿಶೇಷ ಸಂಗತಿ ಏನಂತ ಹೇಳಿದರೆ, ನಾನು ಡಿಗ್ರಿ ಸ್ಟೂಡೆಂಟ್, ಬಟ್ ಇಲ್ಲಿ ಡಿಗ್ರಿ ಸ್ಟೂಡೆಂಟ್ಗಿಂತ ಹೆಚ್ಚಾಗಿ PU ಮಕ್ಕಳು ಬಂದಿದ್ದಾರೆ. PU ಮಕ್ಕಳನ್ನು ನೆನೆಸುವಾಗ ನನಗೆ ಒಂದೇ ಕೊಡಬಾರ್ದು, ಜಸ್ಟ್ ಲೈಕ್ ಅ ವಾವ್. ಯಾಕಂತ ಹೇಳಿದರೆ ಅವರಲ್ಲಿ ಜಸ್ಟ್ ಲೈಕ್ ಅ ವಾವ್. ಅವರಲ್ಲಿ ಇರುವಂತಹ IQ ಆಗಿರ್ಬೋದು, ಆ ಪ್ರೆಸೆಂಟೇಷನ್ ಸ್ಕಿಲ್ಸ್ ಆಗಿರ್ಬೋದು. ಮೇ ಬಿ ನಾನು ಕಲಿಯೋದಕ್ಕೆ ಸ್ವಲ್ಪ ಲೇಟ್ ಮಾಡಿದೆ ಅಂತ ನನಗೆ ಆಗ ಅನಿಸಿತ್ತು. ಖಂಡಿತವಾಗಿ ಇದು ಎಲ್ಲರಿಗೂ ಕೂಡ ಒಂದು ದೊಡ್ಡ ಆಪರ್ಚುನಿಟಿ ಮತ್ತು ಒಳ್ಳೆ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಆಗಲಿಕ್ಕೆ ಈ ಒಂದು ವೇದಿಕೆ ಆಗಿದೆ. ಅದರ ಜೊತೆಗೆ ಇನ್ನೊಂದೇನಂತ ಹೇಳಿದರೆ, ಇಲ್ಲಿ ಮೇಂಟೈನ್ ಮಾಡಿದ ಎಲ್ಲ ವ್ಯಾಲೆಂಟೈನ್ಸ್ ಆಗಿರ್ಬೋದು ಅಥವಾ ಪ್ರತಿಯೊಂದಕ್ಕೂ ಕೂಡ ಎಲ್ಲರೂ ಕೂಡ ಅಂದರೆ ಒಂದು ಫೆಸ್ಟ್ ಮಾಡೋದು ಈಸಿ, ಬಟ್ ಅದನ್ನು ಎಂಗೇಜಿಂಗ್ ಮಾಡೋದು ತುಂಬ ಕಷ್ಟ. ಬಟ್ ಇಲ್ಲಿ ಯಾವುದೇ ರೀತಿಯಲ್ಲಿ ಕೂಡ ನಮಗೆ ಹೇಳ್ತೇವಲ್ಲ, ಒಂದು ಸ್ವಲ್ಪ ಗಡಿಬಿಡಿ ಆಯಿತು, ಹಾಗೆ ಆಯಿತು, ಯಾವುದೇ ರೀತಿಯಾದಂಥ ನಮಗೆ ಅದು ಕಾಣಲಿಲ್ಲ. ಎಲ್ಲ ಕೂಡ ಫ್ರೀ ಆಗಿ ಪೊಲೈಟ್ ಆಗಿ ಮಾಡಿದ್ದಾರೆ. ಮತ್ತೆ ನಾವು ಏನೇ ಕೇಳಿದ್ರು ಅಷ್ಟೇ ಸ್ಮೈಲ್ ಮಾಡ್ತಾ ಅಲ್ಲಿ ಹೋಗಿ ಇಲ್ಲಿ ಹೋಗಿ ಅಂತ ಹೇಳಿದ್ರೆ, ಅಂದರೆ ಯಾವಾಗಲೂ ಯಾವುದೇ ಒಂದು ಕಾಲೇಜಿಗೆ ಹೋಗಿ ಫಸ್ಟ್ ಇಂಪ್ರೆಷನ್ ಇಸ್ ಬೆಸ್ಟ್ ಇಂಪ್ರೆಷನ್. ಬಟ್ ಅದು ನನಗೆ ಇಲ್ಲಿ ಕಂಡಿದೆ. ಖಂಡಿತವಾಗಿ ತುಂಬ ಖುಷಿಯಾಗಿದೆ. ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್. ಎಲ್ಲರಿಗೂ ಕೂಡ ಥ್ಯಾಂಕ್ ಯು ಸೊ ಮಚ್.
Thank you everyone who shared their thoughts. Your reflections truly enriched this session. We now proceed to the most awaited part of the evening, the certificate distribution ceremony. To begin with, I would like to request the president of the event, Mr. Ganesh Nayak, to kindly present the paper presentation certificates to the participants. First, we have Ms. Aisha Rasina P, Ms. Reshma Raghuram, Paper Presentation Certificate Award, I request Mr. Ganesh Nayak, President of today's program, to kindly present the certificate. The Best Paper Presentation Award has been presented to Ms. Dhanashri N. and Ms. Aishu Swami Gowda for their paper title, Privilege the Problematic Youth and Impact on Perceived Character Performance among college-going students. Congratulations to both of you. Now, we move on to another exciting part, the announcement of the Psycho-Vision Fest winners. I call upon the chief guest of the event, Dr. Shanmukhi, to kindly present the awards. First event, Inquisitive Minds, which was a quiz competition. The first prize goes to Kiran Kumar and Pranav. which was a dance competition. And the first prize is Yashaswini and team. And the second prize goes to Preetham. And the first prize goes to Yanadip. And both the winners have submitted their short film through online, and the winners are: the second prize was backed by Ritu Dev from Kannada University. The first prize was backed by Yasin Khalil from CA College of Global Studies, Kerala. Congratulations to both of these. And finally, the most awaited announcement, the overall championship. Any guesses? The overall championship of Psycho Vision Fest goes to SDM PU College. I request all the participants, whoever participated from SDM PU College, to kindly come up on stage. Congratulations to the entire team, and congratulations to all the winners, and heartfelt appreciation to every participant who contributed to making this event and the fest meaningful and vibrant. Thank you to our dignitaries as well. We would now like to take a moment to honor our chief guest, Dr. Shanmukhi, as a token of our love, respect and heartfelt gratitude for gracing this occasion. I kindly request Mr. Ganesh Nayak to do the honors. It is now my pleasure to invite our esteemed chief guest, Dr. Shanmukhi, to address the gathering.
So greetings to everyone, all the dignitaries who are on the stage, and the student committee here, the students and all the students who have come. It's my privilege to
host, tell about the valedictory
speech. It's a privilege for me. Thank you so much for giving me this privilege, and I hope you had a very wonderful time. Today's seminar was a very enlightening thing for you all, and 2 days you had this brainstorming sessions on mental health and also on Mental Health Act. So, Mental Health Act. So, as we all are mental health professionals, you students, ourselves, and all people who are stakeholders of mental health professions, not only understood the law, but this has to be taken into practice and inculcate in our lives. It's very important for us. So I thank everybody for nicely attending and enriching yourself with these topics and educating yourself and patiently sitting there and listening to all the enriching talks. Okay, and thank you once again for everybody to give me this opportunity for the valedictory speech. Thanks. I thank the organizers, I thank everybody, I thank the faculty who have invited me today for this SDM college. I had a wonderful experience here, and it's a very vibrating college with a lot of things happening. And today's event, I felt it is so good going back to the college days, and people are just growing, and I really appreciate the students for their enthusiasm and participation. And my best wishes for everybody, each and everybody. I'm sure you will make a successful careers in future. All the best.
Thank you so much, ma'am, for your motivational and kind words. It is my honor to now invite Mr. Ganesh Nayak for the presidential address.
Om Sri Manjunathaya Namaha. Seeking the blessings of our President, Dr. Virendra Hegdeji, and respected Madam Dr. Shanmukhi, clinical psychologist, Hyderabad, and Madam Ashwini, as well as Dr. Suresh Babu, and Mahesh Babu sir, sorry, and Kirtana, the student coordinator for this particular event, and all the faculty members, and my dear students, that only I am observing here, right? My dear students and all the faculty members, right? Let me congratulate first all the prize winners. That is going to be the main event of today's talk. At the outset, I am going to congratulate all the faculty members and organizing committee members, along with their students and all the participants all over from Karnataka, Kerala, and they told that Punjab, as well as Cambodia, one paper presentation is there. And many congratulations to all those who participated and made this particular event a memorable one and fruitful one. Thank you for all that here. And from management side, I am grateful to Dr. Sharmukhi Madam, that all the way she came from in due respect with our institution and the achievement of our institution, observing the achievement of our institution, that she all the way traveled from there, and all the keynote addresses, that ideas that I have gone through that yesterday, I have taken the feedback, and Ms. Kirtana has given a wonderful brief report on that here. days session was a wonderful one here, and all that just because of for you people. Keep it in your mind that here all the pains has been taken by the teachers and all the respected panelists and all that here. This is just for you people, the budding scientist or psychologist or and so that you are pursuing psychology as your passion, right? So take the best outcome of this particular event and try to be a good practitioner, right? I'm not going to give that much at this particular juncture. I know that anyway the time is running out, 5 o'clock. We have to reach our home and everything is there here. But the two few ideas. I'm not a psychologist. I'm a mathematics teacher. Anyway, that mathematics is going to be very tough for you. That's why you are opting that BAS or BSc as your subject, right? But anyway, that the few words about that this particular event or the conference that I got with the particular heading itself is going to be the one which is going to be catching the mental status or mental illness or mental health at this particular moment, why they have chosen. Anyway, that I came to know that here on December 10th, the Human Rights Day, and that is going to be one of the suitable time they have chosen for that year, the event to be happen, so that it was happened that year. And one of the issue that everyone can address to that year is nowadays it is going to be what? Tension. That means the mental illness, isn't it? Right from kindergarten students, I mean from first standard, if they know that they are going to reading that here, then see if they will get the exam, say don't disturb me, I am in tension, right? And to age old, it's quite common that here the word which is going to be one is going to be tension, isn't it? Or everyone is in stressful manner. Our lifetime itself is going to be in that particular way, right? And maybe it is of the different causes it has, right? The loneliness or the syndrome. What syndrome we are going to be only one sitting in the room, and I don't know the technical word. It is going to be one sitting in the room and just observing the mobile and all that here, right? And more than that here, the social media impact and all that here, it is going to be impact of that here. Due to this, all this here, our youngsters, they are going to be in mental illness, or one of the phobia is going to be always with that here. That I am observing in my career so far. Since I have long 33 years of experience in my teaching career that year, I'm finding only some 5 years that the students, they are in different attitude, you can say. The word which is, you are using that different attitude mode that year. Those students, the past 2000 before students, they don't have any such that phobia or anything. They are doing their work regularly, but nowadays the reading habit and all that, it is going to be minimized with respect that maybe the impact is going to be the psychological disorder. That's what I am going to say. Lot of disturbance has going to be happen right here. So how to overcome all that here? That everything that you know that here is going to be everyone has to go for what? You say that our ancestor is going to say that philosophically you have to do pranayama, you do yoga and all that. Definitely it will give the, it is going to be one of the remedy or medicine particular to that here. On December 10th that year, you know that now IT people, the word of that year now it is the, suddenly the technology is going to be revolutionized our India, that to what? To develop the country. The technology is one of the main role it has played to take that from grassroots level to that achievement stage here now. Developed country is going nearer to developing country now here, right? Now the reason for that, everything, okay, technology played a role, but who is behind of that here? The techno people, the IT/BT people, they are contributing to that here. But their lifestyle is entirely, now it is going to be, what we are going to say, is going to be in disturbed mode. My daughter is one among that, is also that here. Every time that here, round the clock, work. There is no, they don't have any much time. Their livelihood, if they want to do that here, there is no time for such that here. On cook madbekadre time illa, right? So to whom to address and all that here. So that this idea should be revamped here, the changed here, the younger generation, all that here, the stress that is going to be change their mood, and they are going to coming out for that here. For that, what is the choice they are taking that here? Not yoga and pranayama and all that here. They are going to be alcohol. They are going to near to alcoholic, and they are going to their druggish that here. All this are going to be see that in metropolitan city. This is going to be the new fashion. Is nowadays, and just because of that is going to be a disorder, mental disorder that here. So now it is you people that I am advising that here, right? You have lot of career opportunities in this particular aspect that here. So be a good mental practitioner, right? And try to treat all those the ideas which is coming out in the next generation that here, right? Make this psychology as a very good subject that I know it very well that here. So most of the PU student they have participated here. They have given a good platform over that here, and all such programs will be just because of that here, right here. To what personality, what is the outcome of that? You people, the student is going to be here. These students that here, so they got one how to make this conduct that particular program, as well as the leadership quality or communication skill that they are going to be getting over that here. These people, what MSc people, and for you PU people that here, this is a very good exposure to you for listening such the well-versed faculty members lectures and all that here, and keep this as your career, right? So mental health professional or any psychologist is going to be, you have a lot of opportunity in counseling side also. Try to involve in that here and shape your future in this regard here. So I thank once again all the faculty members to make this, and all of you to make this particular event a memorable one. Thank you one and all. Survey.
Thank you very much, sir, for your powerful and insightful presidential address. Your words have truly added value to this valedictory session and have given us much to reflect upon. To formally express our gratitude, I now invite the Joint Secretary, Ms. Ashura Faiza, from first year MSc Psychology, to deliver the vote of thanks.
Good evening to one and all present here. We have come to the end of this meaningful two-day national conference on promoting human rights in mental health care, approaches, opportunities and challenges, and Psychovision Fest. I, Ashura Faiza, from first MSc Psychology. It's my privilege to deliver the vote of thanks on behalf of the Department of PG Studies and Research in Psychology, SDM PG Center, UJIRE. First and foremost, I express our profound gratitude to our esteemed President, Dr. D. Hegde, Dharmadhikari of Sri Kshetra Dharmasthala, whose vision, values and constant encouragement make academic initiatives like this truly possible. I extend our sincere gratitude to our respected Principal, Professor Vishwanath conclude the valedictory ceremony. Thank you one and all. Have a wonderful day ahead.
Thank you, Dakshina. Once again, a big congratulations to all the winners, participants, and each and every one for their commitment and dedication in making this event successful. I kindly request the participants from other colleges to join in on the stage for a group photo. The participants from other colleges who have come, please do join in for a group photo. The photo session will be followed by second year's NAAC psychology, followed by the first year's NAAC psychology.
ఉంటుంది దుమ్ముదల అది పంచేది కాదు ఒక అంకుల మాత్రం ఒక ప్లేస్ ఎన్నో ఎపిసోడ్
Second year